Uh, Good evening, everyone, and namaskar. So, on behalf of the Indian National Association for Study of Liver in INASL, I welcome you all to this sixth edition of INASL Clinics on HCC. To tell you, we started these clinics in the month of May, and we were having these clinics every month, barring the month of August, which was our annual meeting month. We have been having it every month, and this is, as I said, is the sixth edition. The only difference is the five editions before this has been, the physical meetings, and we covered five cities across the country. So then there was, a feedback which was coming in that why are you leaving so many other cities? So we thought that this last edition in this series, let's do it on a virtual format and try to connect as many people. I know there's some injustice which has happened to the Kerala and the Kochi team. This was supposed to happen physically at Kochi, but my thanks to them for agreeing for this virtual, meeting and a virtual format for this particular webinar. And all these, months we have been focusing predominantly on, the systemic therapy and the advanced HCC, which was kind of linked to the INASL recent guidelines on HCC, which were brought out. At this point, I think I have to thank one person who has to be, other than obviously the Governing Council of INASL and all the faculty and the delegates, is the course coordinator for this particular, series, which is Dr. Ashish Kumar. And he has been the force behind all this, six editions of HCC. And today also, he will be, taking this forward from here. And I will hand it over to, Dr. Ashish for this particular webinar. Over to you, Dr. Ashish.
Thank you, Dr. Ajay, and namaskar, and good evening to all those who are attending, ladies and gentlemen. So it is my proud privilege to again present to you this is the sixth edition of INASL HCC Clinics. As Dr. Ajay Duseja has rightly pointed out, the background that we have conducted five HCC clinics physically, and the sixth one we are purposefully doing it virtual, so as to up all the lost cities which could not join physically. So I would like to give you a background why we are doing these clinics. So INASL published its guidelines first in 2014 on HCC. The meeting was held at Puri, so we called it as Puri Consensus. And then subsequently, the second edition was held in 2019, and we published the guidelines on 2020. But over last at least 5 years, last 4-5 years, there has been rapid progress in the management of HCC, especially in the intermediate and advanced stage. So the INASL Governing Council decided that this time let us update our guidelines faster. So within 3-4 years, we had the next meeting that was held in 2022, and we focused only on management of intermediate and advanced HCC. And those guidelines were published just in August 2023 in our clinical and experimental hepatology. This time we also, the INASL decided that instead of having presenting these guidelines in one meeting, let us have small single theme meeting on HCC at various places, so that more awareness among the gastroenterologists, surgeon, intervention radiologists, and all those who are managing HCC, more awareness about these guidelines and more awareness about the recent development in HCC can be brought up to their doorstep. So we did small HCC meetings at various places. We started with Kolkata, followed by Chandigarh, and then Bangalore, and then Srinagar, then Ahmedabad, and then the last one was supposed to be held locally at Kochi, but then we have given it a virtual format this time. So our focus in all these small meetings has been to cover the entire aspect of HCC, especially what has been the new in the guidelines, and what is new in the systemic therapy, local regional therapy, liver transplant aspects, intervention radiological aspects, SBRT, and all other recent aspects which have changed the management of HCC in recent few years. So again, so this today evening also we are going to discuss some of these issues in the virtual format, and I'm thankful to uh, Dr. Abraham Koshi, who's the force behind the local Kerala team for organizing this event. And before we move on to actual session, I would hand over to Dr. Abraham to say a few words about
Thank you, Ashish.
these.
It's a pleasure to have this meeting in Kerala, and thank you for the opportunity. The meeting, as you said, will cover all aspects of hepatocellular carcinoma, especially the treatment aspects, and individually about various local regional therapies by experts, and also the new guidelines, because Barcelona guideline is the standard of care that we have always been following, but INASL has improved on it, and we will hear it from Dr. Ashish himself about that. And the whole session will end with some case discussion, so it becomes more clearer and applicable to our physicians and treating doctors. With this, I will end the introduction and hand over back to Ashish.
Thank you, Dr. Koshi. We were also supposed to join by Dr. Subrat Acharya and Dr.
Want to take over?
I'll just, so Dr. Subrat Acharya and Dr. SP Singh was also supposed to join, I think, but due to some reasons, Dr. Subrat Acharya called that he had to rush for some emergency. Dr. SP Singh is probably on the road, but he would join later. So I think I would start the session, and I would ask the Maisha team to display the slide for the first session. And I would, first session is on the changing epidemiology on HCC in India. And this will be moderated by Dr. Matthew Philip. Next slide, please.
Sorry, there was an interruption.
Yeah. So the first session is on the epidemiology of HCC, the changing epidemiology of HCC. It will be moderated by Dr. Matthew Philip. Dr. Matthew Philip is the HOD and senior consultant. He's at the Lisi Institute of Gastroenterology and Hepatology at Kochi, Kerala. He's also the Secretary General of Indian Society of Gastroenterology in India. So I would hand over to Dr. Matthew Philip. He would say a few words, and then he would also introduce the first speaker. So over to you, Dr. Matthew Philip.
Thank you, Ashish. At this opportunity, at this time, I would like to express my sincere gratitude to Indian INASL for giving me this opportunity to be a part of this important session. I agree with you that management of HCC is quite important, and it should be uniform across the country. And similarly, we should also have guidelines which already have to early detection of lesions, where we can impart some cure or good quality of life can be given. But it's very common to see that in spite of all this, we still see a good number of patients, or a major number of patients are approaching you in the where you cannot offer much. They come in BCLC C stage or very advanced liver disease, and so it's actually become a big problem. So I think irrespective of the management, but also I think we should focus more on the early detection of HCC, and I'm sure there are actually guidelines, even INASL has done it. So I think we should dedicate more on physicians, especially gastroenterologists, hepatologists, and all, have a very good surveillance program where we can pick up and diagnose it early. And epidemiology of HCC, I think when compared to the last many years, it has changed a lot, except even today, we see very advanced cases of HCC even today. So I think, we have got a very eminent person to discuss on that. Dr. Abraham Kochi has been in the forefront in Kerala doing studies on HCC, and he already brought out an analysis of our own cases from Kerala, and now he's in another study how whether the delay in picking up these solutions can be notified or not. And I think he's behind in that study. We get mails every day, or at least in a week, that we get mails from him to contribute cases on that. So I think Dr. Abraham Kochi is one of the early generation, I would say that early generation hepatologist of India. And he was very active, and what I understood from others that he was the first one in India to do a sclerotherapy. Am I right? I don't know. See, Abraham Kochi. And then he had varied experience across the world, and I still remember that I got an opinion from him, and he shared his experience when I want to go to Kochi with Dr. Abrak, where he was there, and after that I joined for a training there. So I know him from the very beginning, and then he was working in various countries. I met him in Bern also. So I had a very good association internationally also along with that. So for discussing on this aspect, epidemiology of hepatocellular carcinoma, I think it's a very important aspect. And especially I would request you to tell about what's happening in Kerala also, not only in globally, but also in happening in Kerala. So may I request Dr. Abraham Kochi to start his lecture on epidemiology of hepatocellular carcinoma.
Thank you. Thank you, Dr. Matthew. We'll talk about the epidemiology of hepatocellular carcinoma. The incidence of hepatocellular carcinoma worldwide and its etiology is quite varied. We'll come to India later, but you will see, for example, that in Australia, there's a large proportion of those with...
Can't see the slides, sir.
You can't see the slide. It's coming on mine. I don't know why it's not coming on yours. It's shared.
Others can see?
No.
No. Admin team, can you just reshare, sir? Can you just reshare?
I will go back and reshare.
Okay.
Can you see now? No. Share screen.
I think we'll make it full screen.
Now we can see full.
You can see, I'll make it full screen.
Yeah, full screen.
Okay. Okay, is it okay now?
Oh, fine.
Yes.
Okay. So the incidence of hepatocellular carcinoma worldwide is quite varied, and the etiology is also quite varied. So you will see that in China, for example, and in the Far East, in China, it is predominantly hepatitis B. And in countries like Australia, there is a large proportion of NASH. And in different countries, these proportions are varying. So throughout the world, it's not the same scenario. In different parts, different etiologies play a part. In some parts, for example, in Egypt, it is mostly hepatitis C. So these are very varied. And we will come to India because one has to tailor the surveillance and management according to what is prevalent in each country. So hepatitis C, hepatocellular carcinoma in India, there was a good review by Dr. Acharya. It's a little old, 2014, but he said that the prevalence and incidence is uncertain. And there was a wide range which was given, different methodology which was used. But the range you can see is almost tenfold. So from 0.7 to 7.5 per lakh population for men. And for women, again, it was a very wide range. So this wide range is because no good study was there to ascertain the actual prevalence and incidence in India. Now, two large studies have recently been done. The previous studies had shown that, from about last 10 years, that hepatitis B virus, like in China, was the predominant cause of, or the etiology, or the association with hepatocellular carcinoma in India also. However, two large studies have come this year. One from Kerala, which included all the field hospitals, smaller hospitals throughout the state, and another multicentric, predominantly from large hospitals, Delhi, Bombay, Vellore, and few other centers, but predominantly large centers, Chandigarh. So these two studies done this year show, both studies show that NASH rather than hepatitis B is the predominant etiology. So the percentage of hepatocellular carcinoma due to NASH or associated with NASH is almost 40%. Alcohol is next. It's varying between the two studies, but it's next. And hepatitis B is lower down. So clearly, the pattern of association or etiology of hepatocellular carcinoma is changing. And now it appears that NASH rather than hepatitis B is the predominant association or etiology for hepatocellular carcinoma in India. So it's not only Kerala, but also throughout the country. So when you take both these studies, the references are given at the bottom. Both these studies, the age distribution, you see that almost similar, somewhat slight differences, but almost similar. It predominantly from 50 to 70 years. So that's the age distribution. And both studies show it is predominantly male patients. So mean age in Kerala is 63, in the multi-center is somewhat similar. The sex, 80 to 90% is male. So these two are important when you think about surveillance also, because one needs to concentrate on these people. You need to concentrate on the men rather than the women, and you need to concentrate between the age of 50 and 70. Cirrhosis is 70 to 90%. So again, like the AASLD and other guidelines, including INASL, the focus is on cirrhotics. All cirrhotics must be screened because 70 to 90% of the hepatocellular carcinoma occurs in cirrhotics. Of course, the Asian guideline says that you also need to look at hepatitis B virus because that is an oncogenic virus. We'll come to that in a minute. However, the sad part, as Dr. Matthew Philip was also mentioning, is that in the study in Kerala, only 20% were within Milan. That means potentially curable patients are a small group. This is very sad because we would like it to be the opposite. We would like potentially curable disease detection in 80% rather than 20%. It will be, for various reasons, almost impossible to reach 100%, but at least we should aim to get 80%. However, actual curative treatment offered or done is only 5%. That is either liver transplant or curative resection, which are considered curative, actually occurred only in 5% for various logistic, financial, other reasons. So this is dismal. So I think one needs to keep it in mind and see where we need to improve. That's the most important message. Now coming to the non-cirrhotic, he said 70 to 90% is associated with cirrhosis. However, the non-cirrhotic group is also important. And when you look at combined data from both the Kerala and this multi-center study, you find that in comparison to patients with alcoholic non-cirrhotic HCC, where only 6% of the alcoholic HCC, alcohol-related HCC, is non-cirrhotic. Both HBV and NASH, it's about 25%, and this is highly significant. Earlier guidelines stated, including the Asia-Pacific guideline and Chinese and Far East guidelines, that people above the age of 50, males, should be screened for hepatocellular carcinoma, even if they do not have cirrhosis. I think now it is becoming more and more apparent that even NASH patients are behaving in a way like the initial slide that I mentioned, Acharya's paper. We still do not have a very good epidemiological study, and a good epidemiological study is still required in India. We saw that early diagnosis in a treatable stage was occurring only in 20%, and actual treatment was curative treatment was being given only in 5%. And we clearly need to improve early diagnosis and access to curative therapy. Clearly, that is a need. And thirdly, we need to, because NASH is becoming the #1 etiological factor, one needs to control NASH, and associated with NASH, there is diabetes, which is also creating a problem, metabolic syndrome, and predisposition to both cirrhosis as well as cancer. So we need to control NASH and diabetes, and these are important take-home from the epidemiological data that we have in India. So in summary, the prevalence, when you take roughly, it's approximately 4 per 100,000 or lakh in India. The etiology, as we see it now, is predominantly NASH, about 40%. The age is 50 to 70, and about 90% are males. And 90% is associated with cirrhosis. Unfortunately, 80% of them come or are detected at an advanced stage, and one clearly needs to try and make a difference at this point. And we also need to address, although smaller proportion, the possibly increasing prevalence of non-cirrhotic HCC, which will come with NASH. Thank you.
Thank you, Dr. Abraham Hoshi, for this very interesting and thought-provoking presentation. In fact, you have put in more questions than answers on that. So I think we need that. Actually shows that there is many questions need to be answered on the epidemiology of hepatocellular carcinoma in India. And being as a gastroenterologist looking after patients with cirrhosis for so many years, and still I feel the curative percentage of hepatocellular carcinoma, even today, just like what we see in carcinoma of pancreas, it is still at a very low rate. So how we can improve? And that is, I think the society should work on that. And I just want to make some comments and questions. Is there any questions on the chat box? I think I will take it up initially. And one is that, I just want to tell you that in NFL, in Kerala, what I have noticed that there is a combination of MASLD plus alcoholism. So I many times, we do not know that what actually caused their liver disease or not. Second is when a patient, when we label them as MASLD or the so-called NASH, at what stage we should start recommending them for screening, because we don't know the answer. Is it at a particular fibrosis values, or all the patients of fatty liver, it is difficult, or all the patients of, otherwise we have to find out some high-risk factors. For example, what I have noticed is that patients with diabetes, and many of them actually, when you incidentally evaluate them, they have got cirrhosis. It's actually because of the longer the duration of diabetes and the association of so-called fatty liver or MASLD that ultimately lead on to cirrhosis. And I think there is a point in actually screening select population like diabetes people, as you told, people of 50 years to 70 years, and all those patients, I think, needs to be picked up or try to be found out that. So I want to know from all of you, what is the best modality for evaluating or screening these patients? Is just ultrasound every 6 months, ultrasound plus alpha-fetoprotein, or ultrasound for alpha-fetoprotein plus PIVCA, or along with that, yearly one CT scan or MRI, another cross-sectional imaging. So I think, many times we have seen that patients who are especially non-adherent, or they are actually not a regular delay in actually review, they develop hepatocellular carcinoma. It's very surprising. You have done ultrasound and the patient did not come for another 9 months, 10 months. Then they come and you do ultrasound, you pick up a lesion. Whether he actually missed it on the previous one, we don't know. So I think, we have to have some guidelines on that. And I'm sure I want to get opinion from others also. And Dr. Abraham Kochi, what is our protocol of screening for hepatocellular carcinoma? Is it just ultrasound plus alpha-fetoprotein or anything more than that?
So far, we are still using whatever guideline is there from ASLD and the INASL. But I think there is a case for modifying it a little bit.
I think so. Ashish, what is your experience?
So what in recent 4-5 years, what we have been seeing is that we are getting more and more cases of patients who are having NASH-related NASH without cirrhosis and having large HCCs. So already when surveillance program for HCC in cirrhotics has not been very much successful, in spite of repeated guidelines which have been saying that we need to do ultrasound and AFP and other tumor markers every 6 months, still we used to get large HCCs and many of the patients were missed. And now with the emergence of NASH and having who are not even in any surveillance program, so the case is becoming much more alarming. So there are at present no guidelines which suggest screening of entire NASH population, but there is some suggestion, I think, from the ACG or some guidelines which does say that patients who have advanced liver fibrosis, although not cirrhotic, can be subjected to surveillance program, but they were also not clear how the surveillance can be done. Should it be done similarly as in 6-monthly ultrasound and AFP as in cirrhotic population, or the frequency should be lesser, maybe 9 months or 1 year, but that was not clear. So it's a difficult, challenging situation, and maybe others can also add.
Can I come in, Dr.
Ajay Duseja, what's your comment?
Yes, so, sir, before that, Dr. Koshi, can you please stop sharing the slides?
Stop sharing. You will just close the PowerPoint.
You got any more slides?
Yeah.
Yes. Thank you.
Okay, sorry.
Very, very nice and informative talks. So just 2-3 points to add on. One is, in addition, we know that the prevalence, the studies show, including from our center, around 900 patients, that the both alcohol and NASH, are becoming more commoner. So what we had done was we had actually looked at the trend for last 10 years. And we could actually show for the first time that there is a changing trend, which means hepatitis B and C combined together still today, maybe around 35% would constitute still maybe the commonest cause of HCC in this country. But the trend is that both NASH and alcohol are going up over the last 10 years or so. That is one. The second information which we came out was that around 14% of our 1,000 patients were non-cirrhotic, and of these 14% non-cirrhotic, there were only 2 etiologies. One was hepatitis B virus, 50% of them were hepatitis B, and the other 50% was NASH. So if somebody asks what is the 2 common causes for non-cirrhotic HCC, then it is only hepatitis B and NASH. Hep C will always go through almost always through cirrhosis and the other etiologies as well. That is one. Regarding the screening and surveillance program, the issue is except the AGA guidelines which had come and suggested that you should be screening the advanced chronic liver disease, nobody else suggests that, and the reason is that you need to have a certain kind of incidence of HCC occurring in a particular group of population before you suggest screening in that particular group. So that is qualified in a cirrhotic, but not qualified in a non-cirrhotic. So till date, except the AGA, which suggests that if somebody has a FIB4 more than 2.67, you can actually screen. But other than that, nobody else does it. And I think rightly does show that probably we are not still there to start screening the non-cirrhotic NASH HCC. The last point is, there are certain LIRADS criteria for screening and for surveillance, and there is a very good suggestion that patients with NASH, obese patients, alcohol with obese patients, where there is a limitation of ultrasound, and they have given those LIRADS criteria, there I think you can use the modalities, and this most of the guidelines would agree. You can either use a CT or MRI for screening and surveillance in them, where you feel that the ultrasound is limited by obesity or because of various other reasons. That's it. Thank you.
And any more questions? The admin team questions questions are posted there. I don't see any. And Aju Matthew, you want to make a comment? Aju Matthew has put a question. A comment is posted there. Aju, are you there?
Yes, I am here, sir. No, I just wanted to present the data that we published just a few months ago at the American Society of Clinical Oncology conference, showing that there has been an increase of nearly 11% in a decade pan-India. This was based on a population-based cancer registry data. The absolute incidence of HCC currently is around 3.3 per 1 lakh patients. So I think it is probably an underestimation, especially with rising metabolic syndrome. So this is actually a burden that we are all seeing as oncologists as well in clinics. But thank you for the talk and thank you for the interesting questions.
Yeah, Dr. Abraham Kochi, I know many of you are gastroenterologists as well. See, what is the commonest cancer you see? To me, the commonest cancer I see today is hepatocellular carcinoma. It is not carcinoma stomach, it is not carcinoma colon. The commonest what I see is hepatocellular carcinoma. And in our tumor board, every week we have got tumor board. 50% of the cases we discuss are hepatocellular carcinoma. Ashish, you are a gastroenterologist as well as a hepatologist. What is your opinion?
We also have tumor board every week, and so every week at least 2 or 3 cases. In the entire tumor board, we discuss about 4 or 5 cases. But out of them, 2 or 3 are of HCC. So proportion of entire GI cancer among them, HCC seems to be about 30% or 40% now. And the all other like CAGB and stomach cancers, colon cancer combined maybe 60%.
We fortunately we don't see much of CAGB, but no, all other cancers are there. But in spite of all this, the number of the volume as such, if you look at, I think hepatocellular carcinoma is much more detected. Any other comments anybody wants to make? Dr. Abraham Kochi, any final comments from you? So thanks a lot. I think, if there are no further questions, I think we'll move on to the next. And I would like to thank Professor Abraham Kochi for this wonderful talk and thought-provoking suggestions on this, and wonderful comments by Ashish as well as by Ajay Duseja. And I suggest that INSL do further, because when the society becomes important, when actually they find out what is the current problem of that particular specialty, and then work on that. And I think HCC is actually a real problem. And of course, MASLD is there, but HCC is a problem where we early pickup can actually recover the patient or even cure the patient. So I think you should work on that. And once again, appreciate and thank INSL for this wonderful opportunity. Thanks a lot.
Thank you, Dr. Matthew Phillips. So we move on to the next session. The next session is on the INASL HCC guidelines 2023, what's new. So I would hand over to Dr. Sunil Kumar K to introduce this topic.
Senior colleagues and friends, good evening. The next topic is an important one. As Abraham Kochi sir rightly said, we are detecting the HCC in a very late stage where we cannot offer much. And the existing guidelines has got some limitations in managing, especially in the Indian scenario. The recently published INASL guidelines has suggested some modifications, some recommendation has been made. To enlighten us on this topic, like changes made in the staging and the treatment aspects, downstaging, treatment stage migration, etc. We have Professor Ashish Kumar here, who needs no introduction to this gathering. I invite Sir to present the topic on the recent changes of INASL guidelines.
Thank you, Dr. Sunil. Technical team, you can stop sharing so that I can share my slides here. So are my slides visible?
Yes, sir.
Okay. So the INASL HCC guidelines, what's new? As I mentioned before, INASL first published guidelines on HCC in 2014 and then revised it in 2019, followed by the final revision, which we did in 2023. Meanwhile, ISL's last guideline on HCC were published in 2018, and ASLD has also recently published their recent update of the guidelines in 2023. So most of these revisions have now incorporated many of the changes which have occurred in HCC management over last few years. So the INASL guidelines were published in August 2023 in the Journal of Clinical and Experimental Hepatology. It will be soon available in the PubMed. The first INASL guidelines were published in 2013. The meeting was held in Puri. So we have started calling these guidelines as Puri guidelines, Puri recommendations. The second meeting in 2018 and the third meeting again in 2022. So what is new in the INASL 2023 guidelines? So this time it was focused mainly on intermediate and advanced HCC because over last about 4 or 5 years, we have realized there has been rapid advancement in the management of HCC, especially in these stages. All the diagnosis and surveillance has largely remained same as in previous years, but there have been many advancements in these stages. And INASL also, in addition, has slightly modified the staging system, which I'll discuss in detail, which is more in tune with the current practices in India. And also in the staging system as well as in the management algorithm, now we are focusing more on combination therapies because newer evidence point out that when we combine therapy, for example, when we combine loco-regional therapy with systemic therapy, it has got superior efficacy and longer term survival. Then we've also introduced the role of SBRT, which has come over in last 4 or 5 years. So we've introduced this in the algorithm because emerging data has shown excellent results. So what is new in staging? So we are familiar with the BCLC staging, which has been modified multiple times, and the last one was published in 2022. Which classifies HCC into the 5 groups. Very early HCC stage 0, stage A, that is early stage, intermediate stage, advanced stage, and the terminal stage. And further, they have divided the intermediate stage into 3 groups, and they have given their own algorithm. But we have slightly further enhanced the staging with further subdivisions, like we have further subdivided stage A into stage A1, A2, B into stage B1, B2, B3, stage C into C1, C2, and D into D1, D2. So what are the meaning of these stages? I'll come to that. So what were the shortcomings of BCLC staging? So in the shortcomings, there was no mention of the combination treatment. For example, all the treatments they had mentioned according to stage was single modality treatment. For example, in intermediate stage, you would give a TACE. In the advanced stage, you would give systemic therapy. In terminal stage, you would give best supportive care. So the combination therapy was not mentioned. In the intermediate stage, there is a good role for TARE, but it was not mentioned in the BCLC staging. The downstaging was also not incorporated in the algorithm of the BCLC staging. And the BCLC staging was not very well suited for the LDLT settings. And other shortcoming of BCLC staging was that the stage C, all those patients who had portal vein thrombosis with no extrahepatic metastasis is clubbed with those having extrahepatic metastasis. And they've combined these stages and they call it as advanced stage, where they offer only systemic treatment. And in the advanced stage, the BCLC mentioned that there was, even if the tumor was small, there's no option for liver transplantation, and the only treatment they have offered was best supportive care. Also, in the shortcoming of BCLC staging, there was no mention of SBRT, which has got a very emerging role. And the liver function assessment in the BCLC staging was very heterogeneous, and they've mentioned that it can be done either through LB score or Child-Pugh score, MELD score. So it would depend on centers to center what they would follow. So this introduced a lot of heterogeneity. So what INASL has done, that we have tried to overcome these shortcomings. I'll come to them one by one. So what INASL has done, that we have incorporated liver transplant criteria into the staging. So if the patient is within Milan criteria, he's now in stage A. That means that either he has a single nodule less than 5 centimeter or less than 3 nodules, all of less than 3 centimeters. So if it is within Milan criteria, he belongs to stage A. But if he belongs to an expanded criteria or extended criteria, such as UCSF criteria or beyond, then he would be labeled as stage B, especially stage B1. So we have incorporated the liver transplantation criteria in the staging itself, which was not there in the BCLC staging. So second thing which we have done is we have incorporated downstaging. The BCLC does not mention when we should do downstaging and when we can proceed for upfront liver transplantation. So what we have said, that if the patient is in stage A, that is, he is in Milan criteria, he can undergo upfront liver transplantation. If he's in the UCSF stage, within UCSF stage, that means stage B1, he can again undergo upfront liver transplantation. But if the patient is beyond UCSF criteria, it is preferable that we first downstage these patients and only then subject to transplantation. And if liver transplantation is not available, then the patient moves to the next stage. That means he has to undergo either TACE or TARE. And there is a definite role of transplantation. We have got good evidence, even from multiple studies, even studies done in India. This is from the Dr. A.B. Soin's group, which has showed that the patient who come in advanced stages, that means those who are having beyond UCSF staging, these patients have got high risk group and they have high risk for recurrence. So it is better to do downstaging in these patients before taking up for transplantation. The other shortcoming of the BCLC staging was that there was no mention of the TARE. So intermediate stage, they have mentioned that these patients should undergo TACE. But there are a lot of data which have indicated that TARE could be a good option, even in patients who have nodular HCCs. TARE is a good option. They can undergo either TACE or TARE, but there's a definite indication of TARE in patients who have infiltrative HCC or which has got bilobar involvement or extensive involvement. There, these patients cannot undergo TACE. Then the TARE is a good option for them. And even in stage with portal vein tumor thrombosis, TARE can be possible. So we have incorporated TARE, and there have been studies which have compared TACE versus TARE and found that TARE has got superior efficacy and longer term survival. Although TARE is expensive, so we have given the option of TACE as well as TARE. If the patient can afford TARE, why not offer TARE to these patients? Coming to the next thing, that is stage C. The BCLC has clubbed these patients into one group, whether the patient has got portal vein tumor thrombosis or whether he has got extrahepatic spread. And these patients were offered systemic treatment, where the INASL has now subdivided these patients of intermediate stage into C1. C1 are those patients who are having portal vein invasion without any extrahepatic stage. And these patients would benefit from loco-regional treatments. For example, they can benefit from TARE. SBRT has got very good option for these patients and very good result. And even in limited patients, resection can be done these patients, and there have been some studies for them. So patient with C1, that means those patients who do not have extrahepatic metastasis, loco-regional treatment can be offered, followed by systemic therapy. While those patients who have extrahepatic spread, these are labeled as C2, and these patients would undergo systemic treatment. And can we do liver transplantation in stage D patient? The BCLC doesn't offer these patients for liver transplantation. They just mentioned that these patients should be given only best supportive care. But we have further classified the terminal stage D, into two types of stage D1. That means those patients who have small tumor burden, whose tumor fits within the UCSF criteria, and their performance status is good, then these patients would definitely benefit if they are offered transplantation, and their survival is equivalent to those patients who do not have HCC but have decompensated chronic liver disease. So stage D1, that means tumor burden is small, then you can offer liver transplantation. Stage D2, that means either their tumor burden is beyond transplant criteria or they have a poor performance status, then obviously then you will offer best supportive care. And there are many studies which have come up, which have shown that in patients with decompensated chronic liver disease with small HCC, the transplantation can be offered, and these patients have longer-term survival. What about combination therapy? Now, more and more studies have come up which are showing that patients who have undergone loco-regional therapy, if we add systemic therapy in the form of either immunotherapy or we add tyrosine kinase inhibitor, these patients have better survival. So many studies have come up. For example, this study showed that TACE plus lenvatinib, these patients have a much better survival as compared to TACE alone. And even a study which was published in October 2023, the IM Brave 050 study, where they offered atezo-bev to those patients who had undergone curative resection, such as ablation or resection. When offered atezo-bev, their recurrence-free survival was better. So there's a clear-cut role of combination therapy. So the BCLC staging does not mention any combination therapy, but we have said that patients, after giving loco-regional therapy, if we combine them and we subsequently give them combination systemic therapy, their survival, recurrence-free survival and overall survival is improved. What about role of SBRT? In last few years, we have seen a good role of SBRT, which is a cheaper alternative to loco-regional therapy. And there's been many studies in a recent trial, StarFit trial, have shown that if we combine SBRT with transarterial chemoembolization and followed by immunotherapy, these patients, even with advanced HCC, can have good survival, and they can even be downstage and then can be offered liver transplantation as well as resection. So with the advent of SBRT, we have incorporated SBRT in the BCLC staging. In INASL BCLC staging, we have said that in patients who have intermediate stage, you can offer SBRT, and in patients who have portal vein tumor invasion, then SBRT has got a good role, and these patients would benefit from SBRT. So to summarize, ladies and gentlemen, INASL HCC guidelines which are published, and I urge all of you to use them because these are updated. These are suitable for Indian setting. These are available in the JCH website. And the INASL BCLC staging system is a significant improvement over the existing updated BCLC staging system. And I would incorporate you to take a screenshot of the INASL BCLC's staging system and keep it in your mobile so that you can use it in your research as well as clinical management of these patients. Thank you for your patient hearing, and I would be happy to take any questions.
Thank you, sir, for the excellent presentation. There are no questions in the chat box. Sir, I have a question. With this, we have this treatment stage migration and all this BCLC C and D is divided into two groups. So, is there a possibility that more and more patients will be subjected to expensive treatment without getting much benefit?
See, patients, we have to offer them the best treatment. The costs, we have to take into consideration the cost factors and the availability. That is true. And for especially in the resource poor setting like India, we have to be cognizant of the cost setting. But just by saying that the treatment is expensive, so we cannot offer them the expensive treatment even to the patients who can afford, would be wrong. And then patients may turn back to us and say that why did you did not offer which is there in other guidelines like ASLD guidelines, EASL guidelines, where there are that the treatment may be expensive when we combine these treatments, for example, local regional therapy or the atezolizumab, which is expensive therapy. So we have to offer them the expensive treatment, which have shown superior survival, but we also have to offer, tell them the alternatives also. For example, there are good data to suggest that if as compared to, for example, transarterial radioembolization, TARE, SBRT is a cheaper option. So patients who have tumor thrombosis, portal vein tumor thrombosis, they can be offered both TARE as well as SBRT. So we have both the options. So once we have given all the options, then it will depend on local setting as well as availability and the affordability of the patient, what he can choose from the treatment.
Okay. And downstaging is a new concept in the INASL BCL and the latest INASL 18. How long we are supposed to wait for these patients?
So one of the important consideration of downstaging is that we have to, after you have given them downstaging, you have to wait for minimum 3 months period, because that is the time we will know about the tumor biology. So there are patients who undergo downstaging and immediately they are subjected to transplantation. That is wrong. So we have clearly mentioned in the guidelines that unless you wait for 3 months, then only you'll know the effect of downstaging. So within these 3 months, if the tumor further advances, then these patients should not be subjected to transplantation. And waiting is the most important thing, that we have to wait and then we have to understand the tumor biology. So if once we have given them downstaging with local regional therapy, either SBRT, TARE, TACE, and then we wait for 3 months and to see how is the tumor behaving, and only then they are subject to further treatment.
Thank you, sir. Any more questions from the audience?
Yes. Hi, Professor. My question is basically the extension of the same what Dr. Sunil was asking, sir. We used to use, for our TARE purposes, we used to use radioiodine way back in 2015. And my radiologist was charging around, I mean, the hospital was charging around 2 to 3 lakh rupees for per session while using the radioiodine. But those days we're using yttrium also. And now recently he has almost stopped completely using the radioiodine, and yttrium costs around 11 lakh rupees for a session, which is almost, more than half the cost of a liver transplant, which can obviously cure the patient. Do you also see the same trend? And I don't know why the radioiodine is not being available it was coming from Baba Atomic Research Center, Mumbai, to our hospital. It no longer comes from there. I don't know what is the process in that. And do you use radioiodine in your practice at your hospital, or it's all yttrium-based radiotherapy now?
I think it is now has been replaced by yttrium now all over, and this is due to most of the data which has come, especially from the Western countries, that they have used yttrium. So there has been switch over to now from radioiodine to yttrium. But I urge everyone. That is why we have said in the guidelines that we need to generate more data from India, and which can be of a lesser cost and more affordable to the patient and more suitable to our resource-free poor setting. I think Dr. Ajay has a comment. Yeah.
So just to add on to, we at the PGI have been using, especially for poor patients, yttrium even in PGI would cost around 6 to 7 lakhs of rupees. So what we have been doing is we have an in-house generator. The nuclear medicine people have the in-house generator, and they actually have been using two more radioactive agents. One is the rhenium 188. We have had reasonably okay results with rhenium 188. And very lately, they had started using even lutetium also. So lutetium, we were not very happy. We had some bone marrow suppression issues with lutetium, but rhenium, we were very, very happy. And so if you were using rhenium in-house generator, and it will cost only around 60 to 70,000 rupees. So I think this is mainly for those patients who can't afford Y90 when you've been using that.
Yeah, that's an excellent thing. I think you should encourage your nuclear medicine people to publish these results, so that once by next update, we can say that in our guidelines that these could be an alternative to the expensive.
Small number they have published, but yes, I think they need to compile the data. Sure.
Yeah. Dr. Sunil, over to you.
If no more questions are there, we will move on to the next session. Thank you, Ashit sir, once again for the excellent presentation.
Okay, thank you, Dr. Sunil. So we would move to the next session. Technical team, can you display the name of the session? So the next session is on liver transplantation for HCC, how, when, and for whom. And to moderate this session, next slide, please. I invite Dr. Shiraj Ahmed Rathe. He is a senior consultant and head of multivisceral transplant at KIMS Health in Trivandrum. So I hand over to Dr. Shiraj to introduce the topic as well as the speaker. Dr. Shiraj.
Thank you, Professor. Thank you. It's at the outset, it's my privilege to chair this, moderate this session with the eminent faculty, national and internationally renowned faculty. And it's even more pleasure to introduce my own friend and colleague, Dr. Dinesh Balakrishnan, who is a senior consultant at Amrita Institute of Medical Sciences, Kochi, a transplant surgeon. And I think this is a very pertinent topic and very close to my heart. Liver transplantation for SC. These three questions: how, when, and whom. They always hunt me on a tumor board meeting, and I'm sure that most of you would have felt the same. Particularly the transplant surgeons would have felt the same. That when you opt for a transplant, there are other colleagues who would always try to disagree or have their own reasons for that, for the disagreement. And I would be happy to see what my other transplant colleague surgeon is feeling. Like the general perception is that the transplant surgeons would push for a transplant, and I always try to sort of convince my colleagues, and that is I think the INASL has a more role to play in publishing the guidelines, which should be widely spread and probably followed in a true spirit. Without wasting further time, I would request Dr. Dinesh Balakrishnan to kindly start sharing his screen.
Dr. Dinesh, are you there?
Dr. Ashish, if he's not there, you can move on to the next.
No,
Please, he's
Dr.
there.
Dinesh.
Yeah, I'm here. I'm here. Sorry, sorry.
Yeah. Okay.
Joining. Just give me a second. Am I audible?
Yeah. Yes.
And, sorry, I'll share. This one. Yeah. So is the screen visible?
Yes, we can see it, Dr. Dinesh.
Okay. Yeah. Okay. I think. Thank you, Shiraz, for the introduction, and a very good evening to all the faculty and colleagues who are joining this meeting. Greetings from Amrita Institute. So I'll in the next 8 to 10 minutes, I will try to present the topic that's given to me. So as we all know, liver transplant for HCC, especially for early stage HCC, has very good oncological outcomes. But whenever we are talking about transplant for HCC, we have to revisit the basic principles of bioethics. So autonomy, which is the patient's right to informed consent and decision making. And many a time in a country like India, this is tempered by communitarianism, which is the support that the family and his close relatives have on his decision making. Also the principles of beneficence, non-maleficence, justice, and utilitarianism comes into play. So depending on the HCC model that you are adopting depends on whether the program is a deceased donor liver transplant program, like in the West, where distributive justice, bringing in the maximum good to the maximum number of people, equity, all this comes into play. Whereas in a country like ours, where deceased donation is very rare, and the program is largely a live donor liver transplant, the principles of autonomy, beneficence, and non-maleficence comes into play. Now, we all know that the most validated criteria is the Milan criteria, but it's very restrictive. Only 30% of patients would strictly come within the Milan criteria. And as we try to expand on the morphological limits of the selection criteria, the risk of recurrence following liver transplant is high. So we all know that we are trying to look at tumor biology, and one way of looking at it is to incorporate surrogate markers of biology, which are the serological markers. And this is a Venn diagram. This is from a publication from Kim et al., where they have looked at the different criteria. So as we all know, the Milan criteria, which is based on size and number, the expansion of that, the UCSF up to 7. So the various criteria based on size and radiology. Now the surrogate markers like AFP is incorporated into the Kyoto criteria, the Kyushu criteria, the 500, where an AFP less than 500 is incorporated into the criteria. And these criteria are usually used in the live donor setting. You also have various scoring systems like the moral and the retreat score, which incorporates AFP and PIVCA into the scoring system to predict the risk of recurrence. And last but not the least, though it is not a practice to take a biopsy from an HCC, pathological factors also come into play when we are talking about recurrence following transplantation. So are all HCCs the same? They are not. Just to look at a case scenario, this is a 63-year-old bank manager, decompensated cirrhosis, MELD of 30, AFP was 246, PIVCA of 578. He had no SOL on a triple phase CT, and we repeated another imaging like a contrast enhanced MRI. A PET scan was done, no suspicious FDG uptake anywhere. We had, like Dr. Shiraz said, we had an MDT, a tumor board on all cases like this. And then it was decided that because his son was a willing donor, low risk donor, no fatty liver, no comorbidities, we took him up for a live donor liver transplant. Now the explant biopsy, when you look at it, he had multicentric HCC. The size of the largest lesion, as you can see here, is 1.5 into 1.5 into 0.9, but he had micro and macrovascular emboli. So essentially, you know, the size criteria, or sometimes even the serology, which is a surrogate marker of biology, may not help us. Because in this case, there was a lot of discussion on whether the high PIVCA and the AFP of 240 might be appointed towards a recurrence. So these are scenarios where, like Professor Ashish was saying, we have to look at loco-regional therapy in a tumor board meeting. So right now in a tumor board, this option of loco-regional therapy also is discussed a lot whenever we come across high AFP or PIVCA. Again, another case, a 40-year-old politician had a RFA for a left lobe 4 centimeter HCC, AFP 805 increases to 1540, CT PET, no extrahepatic disease, related donor, decompensated cirrhotic. He was discussed for loco-regional, but everyone felt that he cannot, he would decompensate with further loco-regional therapy. This was a high-risk case, and we have learned from this case that the risk of recurrence is high when you take up such patients for a transplant. At explant, he was found to have a tumor thrombus in the portal vein, in one of the branches of the portal vein. So as we all know, there are various criteria based on whether it's a DDLT or an LDLT program. So you have the Milan, the UCSF, the up to 7, various criteria in the DDLT setting. And in the live donor setting, similarly, there are multiple criteria which people rely on. People have moved away from many of the conventional morphological criteria and try to look at tumor biology and selection when we are thinking of transplant. So the transplantation for HCC working group report was looking at guidelines, and a benchmark, a gold standard benchmark was to have a 60% 5-year survival when you are choosing a patient, an HCC patient for transplant. A minimum 5-year LDLT survival of 60% was thought to be an acceptable benchmark based on multiple studies. Now coming to biological behavior assessment by loco-regional therapy, the eligibility criteria, they have to be child A or B. If they are very decompensated, it's very difficult to choose them up front for a loco-regional therapy like TACE or TARE. And the type of loco-regional therapy again depends, as was discussed in the previous talk, it depends on multiple factors. And we all know that some of these therapies are better or have an immunological advantage over the other. For example, SBRT is now being chosen in patients who can afford SBRT or TARE over the conventional TACE which we were using before more often. And what is the end point of downstaging? Ideally, they have to be downstage to within Milan. But as we all know, more than 50% of patients cannot be downstage to within Milan. So we accept in our tumor board downstaging strategy of within UCSF criteria. And there should be a minimum cool-off time of minimum observation period of at least 3 months. And during these 3 months, if there's any progression like extrahepatic disease, nodal recurrence, macrovascular invasion, then these patients are not chosen for a transplant. And the AFP is also the delta AFP or the AFP slope. If there's an increase in 15 nanogram per ml per month, it portends a very high risk for recurrence. So that's also taken into account when you're giving loco-regional therapy and waiting and reassessing patients for a liver transplant. Now, what is the evidence for loco-regional therapy? Massafera et al. Has done a randomized control trial where they have selected 74 patients, out of which 54 were successfully downstage, 45 were assigned, 23 in one arm and 22 were included in the other arm. And as we can see, the overall and recurrence-free survival is significantly better in the patients who were selected for loco-regional therapy and then chosen for transplant. Obviously, there was a selection process. Patients with good biology and who did not have a recurrence or progression during the loco-regional therapy were chosen, again signifying the importance of choosing the right patients for transplant. Now, I would not dwell too much on this slide because Professor Ashish has explained very clearly the shortcomings of the BCLC staging system and how INASL has improved upon that. So it was a very pertinent discussion, and many of these clinical scenarios we come across and we have to sit down because a lot of people are involved in the care. So when more than 1 or 2 treating teams are involved, we often believe in having an MDT and a tumor board to decide on what is best for an individual patient. Now, as regards live donor versus the DDLT outcomes in HCC, there was there were a few papers which said that the results in LDLT are inferior to DDLT, mainly due to lack of biological selection, increased release of growth factors and cytokines as the liver regenerates. However, large studies, including meta-analysis, now say that the results are comparable between live donor liver transplant and DDLT. Just a glance at our practice, when I'm just retrospectively looking at what our practice and discussion has been, we have been following the up to 7 criteria. If the AFP and PIVCA are elevated, then definitely we'll discuss and take up these patients for loco-regional therapy. Only about 60% of patients that we see in clinics fall within criteria, so we have to discuss about loco-regional and choosing the right patient. And recurrences are troubling, especially in our early experiences in our live donor program. We had, because there was a first degree relative and the patients were decompensated, we had chosen up a few of the high-risk patients who had elevated PIVCA or an AFP which is high and not coming down. And recurrences are troubling, and there is a lot of introspection required before we take up these cases for a transplant. So nowadays we lean towards the test of time to look at the biological behavior and try to choose and let the high-risk cases come to an MDT, undergo loco-regional therapy so that we can choose the right cases. Now, whenever we're talking about live donor liver transplant, again, we have to revisit the principles of bioethics, in that whatever be the need of the patient, a particular patient, one has to look at the donor. And if the donor has any risk, then it is not right ethically to select such a donor for a high-risk liver transplant for HCC. So the expected recipient outcome has to be good. The donor should not have any risk factor, and in such a scenario, probably it is ethical to consider live donor liver transplant. We sometimes come across patients who are not decompensated. The diagnosis of HCC is made when the patient is not aware that he is cirrhotic. On imaging, it's an early cirrhosis, like a child is cirrhotic. AFP is low, even PIVCA is not high, but the tumor is large. Like it's a 10 centimeter lesion, cannot be resected because he has an early cirrhosis. LFT is good, he's not decompensated. We come across such scenarios. And these are cases which we now select for loco-regional therapy. They're suitable for loco-regional, they would not decompensate. We look at how they respond to loco-regional therapy. Now, many a time they have a live donor, they have very strong family relations who are willing to do the best for the family. And after loco-regional, we are able to select patients for transplant. So sometimes, like I saw a patient in the clinic today who had a 10 centimeter lesion, but he's a child is cirrhotic. His AFP is normal. His PIVCA is less than 200. And CT is not showing any thrombus in any of the branches of the portal vein. So this patient would undergo a rigorous evaluation, including a PET scan, sometimes even a biopsy, then undergo loco-regional. We are proposing to do a tear for him and probably look at downstaging and how well he is downstage before we take him up for a liver transplant. So, so on that note, I think I will conclude. I will allow. I think we will have a discussion on this topic. Dr. Shiraz also would want to contribute on his experience, and I would like other faculty members also to give what their opinion on how they would be looking at this particular topic. Thank you very much. Thank you, INASL, for this opportunity to present. I conclude with this slide. Thank you.
Thank you, Dr. Dinesh. Wonderful presentation. I think you touched upon the core dilemmas and the scenarios. I got few comments to make to take a privilege of being moderator. How much importance do you give to PIVCA? Because we saw a couple of times PIVCA being very high in thousands, and after multiple MRIs and PET scans and FAPI PET and all, we couldn't find morphologically a big tumor to sort of not to give him a transplant as an option. And then we went ahead with the transplant, and down the year, 2 years, 3 years, those patients were doing well. And multiple times we heard that PIVCA probably is not at the moment to be considered very seriously. What is your practice, and how seriously do you consider PIVCA and its trend in terms of following the decision making in transplant in your MDT?
And Dr. Shiraz, I completely agree with you. We have a similar experience. When we are working up patients, we often find they do not have a lesion on imaging. And in such patients, we do rigorously image them with CT and even a contrast MRI and fail to find a lesion in the liver. Now, they have a high PIVCA, sometimes even more than 1,000. And we are worried that, maybe they have on explant, we are not now going to find some tumor in the liver. I presented a couple of cases where these were the odd cases, the odd ones which had a tumor, but large majority of them did not have a tumor. On explant also, we did not find a tumor. We went on, actually our policy is to go ahead with the transplant. If you're not finding a lesion, AFP is low, but PIVCA is on the higher side. We give the benefit of transplant. The odd ones I have presented as case reports, they had small lesions and some microvascular invasion, but many a time we have found that there's no correlation. We have not found a tumor in the liver. So I think many criteria do not incorporate PIVCA in isolation. They have included in the scoring system, along with AFP and some complex scores like the retreat and the moral score. PIVCA is incorporated, but in isolation, I don't know how important PIVCA is. We have had similar experiences like what you shared right now.
Yeah. Another thing, the one more dilemma which I quite often come across is if you have a child age cirrhosis patient who is well compensated and he's got a 3.5 centimeter lesion, what is your preference? How do you decide about that patient in your MDAT, and how do you counsel the patient? Is it stable patient, child A, with a 3.5 centimeter HCC on radiological imaging?
So it depends on where the lesion is actually, and whether resection is possible at all. So we look at the obviously the liver test and the platelet count. If the platelet count is very good, it's a surrogate marker of clinically significant portal hypertension. We do an endoscopy to see if he has varices. If none of that is there and the resection is not, it's a segmental resection, not a major hepatectomy, we tend to resect these lesions. Well, if it is not and it's more than a simple resection, like if it's a left lateral, we might resect it. But if it's not so, many a time we end up giving locoregional therapy, and our choice of locoregional therapy has always been microwave, plus or minus TACE. So that's what we have been doing conventionally. The option of TARE expenses preclude, many a time our patients can't afford TARE. SBRT now, many people are discussing, and we are also thinking of offering SBRT as an option. But I don't know, we tend to think about resection if it's a segmental resection.
Do you consider, you've been in UK, you worked there, and I've also worked there for some time. And then in a cirrhotic patient with an SCC, the first option goes a transplant. We have a couple of patients which were offered TACE, 3 centimeter lesion, 2 centimeter lesion. They kept on a follow-up. They lived for 2 years, and then one fine morning they reached your OPD with a massive tumor, portal vein thrombosis. Now family is looking at us, and we have nothing to rather than apologize. I don't know whether we should be. I don't know, Professor Ashish or other eminent speakers agree on this. A cirrhotic liver, even if it is a child A, with an SCC, we must sensitize the patients about transplant. It may not be available to them, but it should come in a discussion. That's what I feel like. Because sometimes even the screening, and you put them on a strict follow-up, particularly after RFA, there are reports in the literature that RFA induces a aggressive behavior in a residual tumor which comes up and gets more vascular invasions. We had to cut a sorry figure and couldn't offer him anything when they develop tumor in the follow-up, which is beyond any transplant criteria.
No, so yeah, I think Dr. Ajay has a comment, but before that, I would also say that most of the guidelines, including INASL guidelines as well as the ASLD and BCLC staging guideline, they all mention that in early stage, if the patient fits into transplant criteria, the best treatment would be transplant, because otherwise, even with resection or ablation, there's a high recurrence rate, up to 70%. So if the patient can afford transplantation, if the transplantation is available, that should be the treatment of choice. Dr. Ajay, would you like to speak?
No, again, I think very nice talk, Dr. Dinesh. I think I must appreciate that. Just 2-3, quick comments. One is about the AFP versus PIVCA. Again, our data shows that around 30% of our patients are what we call AFP negative or AFP non-secretors. And amongst that, the emerging data says, and this is our experience, that the PIVKA2 definitely has a role in AFP negative disease. Other than the scores which you're mentioning, GALAD, now they have removed the AFPL3 from there and they come out only with GAD score. So other than that, I think AFP negative disease, PIVKA2, and what our experience is that if your biomarker is elevated and even if there is no SOL on imaging, we keep following them 3 monthly, and invariably, almost invariably, I would say, we have found a lesion after, say, 6 months or so. So I think it's very important, to follow these biomarkers, and ultimately you will find a lesion if your, the assays are good, number one. The second is about the similar role of PIVKA2 has emerged about the biology of the tumor. Biology of the tumor, we said I'm in high AFP. So similar kind of, biology and relationship with histology and the outcome after resection and transplant has come with PIVKA also. So I think in our practice, I would say that PIVKA2 really helps us a lot. My only question to you is, I think, about the downstaging before liver transplantation. Lot of data on loco-regional, it is an accepted modality for downstaging. What are your thoughts on liver transplantation after downstaging with systemic therapy? Now the systemic therapy can be, kind of curative, or, at least can get rid of your PVTs or for that matter, extrahepatic disease and bring them down to the criteria within transplant, especially, the immunotherapy, atezo-based combinations, and we have had such patients. So what are your thoughts of, liver transplant after systemic therapy, not LRT?
So actually, our experience in this is very limited. However, I would like to share the little bit of experience that we have with atezolizumab and bevacizumab, because like Dr. Shiraz mentioned, all patients are counseled for transplant in early stage HCC. But however, many patients, when they're well, child day cirrhotics, they opt for a loco-regional therapy. So we had an experience where a patient chose a loco-regional therapy and then went on to develop aggressive disease, in the sense that he had a node in the porta and multicentric HCC. Now, the family was very keen on adopting transplant as an option, but we knew that this patient is now having a node. It's an extrahepatic disease. So we put him on systemic therapy, and he underwent treatment with atezolizumab and bevacizumab. Now, surprisingly, after therapy, the node almost completely disappeared. From a 3 centimeter node, it completely shrank. We couldn't see the node, the whole lesion downsized. And because there were a lot of doctors, informed family, a lot of MDT and discussion and high risk for recurrence, we took this patient up for a transplant. Live donor from the family. We did not have a good experience in that there was no tumor recurrence, but this patient had a very bad rejection. For 2 months, he was well. And then we found that his enzymes were going up. We had biopsied, and he had a steroid refractory rejection, went on to develop cholestasis, multiple issues, and finally developed a graft failure. So we lost this patient in the 5th month after transplantation. And then we were reading reports that, yes, systemic therapy does have problems with rejection. We should have waited longer. So that was a bad experience that we had. We have only done a single case of transplant following systemic therapy. Though many patients in the tumor board are now chosen for systemic, but never have we transplanted anyone else after that.
So I think, the certain amount of waiting period is required, once you give immunotherapy. Yeah. Thank
you. Any other question from the audience?
I think we should move to the next session because we are behind schedule.
Yes, sir. Yeah.
Okay, so thank you, speaker and the moderator, Dr. Shiraz. And so we move to the next session. The next session is on advancements in loco-regional therapy. And to moderate this session, I would like to invite Dr. K.T. Shenoy. He is a senior gastroenterologist at Sri Gokulam Medical College and Research Foundation at Trivandrum, and he has worked a lot, especially in the field of hepatitis B and HCC. So over to you, Dr. Shenoy. Introduce the topic and introduce the speaker.
Thank you very much, Dr. Ashish and the team. It is lovely to see you all on a Saturday evening. and we have a very good presentation to be delivered by Dr. Rajesh on the therapy, which is the loco-regional therapy for HCC. Can we have the presentation? Dr. Rajesh?
I'm not able to share the screen.
Yeah. Now you can share.
Okay, sir. Are my slides visible, sir?
No.
Yes. Not slide. You are visible.
You have to reshare again.
Okay, sir.
Yeah, slides are visible now. Can you make it full screen?
Yeah, sure, sir. Yeah. Hope I'm audible.
Yes.
Yeah. Good evening, all. I'll be talking about the advancements in the roco-regional therapy for HCC. We already saw the INASL guidelines by Ashish sir and what all modalities are available for treating HCC. And from Kochi sir's lecture, we got to know that only 20% of patients actually qualify for upfront surgery, be it resection or transplantation. So a vast majority of patients actually need some form of alternative therapy, which should ideally be curative for the early stage disease. And for the intermediate stage disease, it should be able to either bridge or downstage the tumor for transplant. And for the advanced stage diseases, it should be palliative. So this is where the role of interventional radiologist comes in the form of loco-regional therapies. The LRTs can be broadly classified into two groups. One is the ablative therapies and the second is the transarterial therapies. Ablation basically means that you are directly causing tissue destruction, usually with the help of a needle by either injecting a chemical or imparting some form of energy, thermal or non-thermal. It's good for patients with limited tumor burden, solitary lesion of a small size or up to 3 lesions, again of reasonable size. The transarterial therapies, the second group, is basically for patients with a heavy tumor burden, large solitary lesions or multinodular or bilobar lesions. The idea here is that you're entering the tumoral artery and injecting either chemotherapy or radiation therapy with or without embolizing the tumor, the artery. So let's look at the ablative therapies first. We have two groups again, chemical and energy-based ablative therapies. Chemical ablation is more or less obsolete now. Very few centers are using it, mainly because it's cheap. The energy-based ablative techniques are much better and more widely available now. So let's look at all of them one by one briefly. RF ablation has been the workhorse for us for the past 10 to 12 years. The basic idea is that you are imparting high frequency alternating current, causing tissue desiccation and necrosis. It's wonderful for lesions that are less than 3 centimeters in size, and studies have shown that it's almost as good as surgical resection. But for lesions that are more than 3 centimeters in size, we were having issues. There were instances of recurrence and residual tumor. The reason was that the tissue charring that was happening at the tip of the RF needle or the RF probe, it was preventing the propagation of heat to other parts of the tumor. So we were not getting larger ablation zones. And the second point was that the vascularity within the tumor was again preventing uniform heating of the tumor. So companies came up with something called as internally cooled electrodes. So basically this is an RF electrode or an RF needle which is hollow inside, and you can actually perfuse cold saline through it, which will prevent charring, and it will allow the heat to get propagated inside the tumor nicely, and you'll get larger ablation zones. So this has been a game changer, and to such an extent that almost all the commercially available RF electrodes have this technology now. And we are confident enough of ablating lesions that are little larger than 3 centimeter in size. The second thing that has come up is a separable clustered electrode, or something called as an octopus. Again, the idea here is that we have 3 separate RF electrodes which are connected to a single generator. So if you have a lesion that is bigger in size, around 4 to 5 centimeters in size, you can separately insert these electrodes strategically into different parts of the tumor, and you get an overlapping zone of ablation which is much larger than 3 centimeters. So this has again increased our confidence in ablating larger lesions. This is a typical example, around 3.8 centimeter lesion, and it was ablated with an internally cooled electrode. And you can see that the ablation zone is well above 4.5 centimeter. It's complete ablation. Now, even with the recent advances, there were some issues with RF, and that is where microwave ablation has come in. It's again a thermal-based ablation technique, but the way it generates the heat is a little different. It generates an electromagnetic field. So it does not rely on conduction of heat within the tumor, because it's generating its own heat. So you can get faster and larger ablation zones. And secondly, more importantly, it is less affected by the heat sink effect, which was a problem with RF. So any lesion that was close to a major vessel was not getting ablated properly with RF, which was not the case with microwave. So this is a typical example, a lesion which was close to the left branch of portal vein, ablated with the microwave, and we got a good response. Even with microwave, now newer antennas have come in, and we have CO2 based internal cooling, higher wattages up to 140 watts, and we were getting spherical zones of ablation. The initial issues with microwave was that the ablation zone was oval. So there were some areas of residual tumor. Now we have more spherical zones. So again, increased confidence in ablating larger lesions, and we are getting larger ablation zones. Another typical example, around 4.1 centimeter size lesion, subdiaphragmatic paracardiac, and we got almost a 4.9 to 5 centimeter sized ablation zone. Now, coming to cryo, cryo has been around for a while, but it has seen a resurgence in recent years because there is a change in technology. Initially, cryo was using liquid nitrogen, and the probes were very bulky. But now we have much thinner probes, and we are using argon gas. So the idea here is that you're causing direct cellular and vascular injury by alternating freezing and thawing cycles. The advantage over RF and microwave with cryo is that it's less painful. So you can do the procedure under conscious sedation with local anesthesia. You can monitor the ablation nicely with ultrasound or CT compared to microwave and RF. We are getting larger zones of ablation. So the guidelines actually mention that with cryo, you can actually go up to 4 centimeter easily, which is better than microwave and RF, even with the newer needles. And importantly, it does not injure the adjoining blood vessels and gallbladder. So this is how it looks on ultrasound and CT. The ablation zone is nicely defined, and you have to insert multiple probes. Now, there have been comparisons with RF, and it has shown that for lesions that are larger than 3 centimeter in size, cryo provides a better recurrence-free survival with comparable complication rates. So another thing that has come up very recently is irreversible electroporation. This is a non-thermal based ablation technique which uses pulses of high voltage, low energy direct current, creates permanent nanopores in the cell membrane, disrupts the cell homeostasis, and causes apoptosis. This is the only commercially available machine of IRE that is available. This is a typical example, lesion in the caudate lobe abutting the gallbladder. Multiple IRE antennas were inserted, and we got a good ablation zone. Now, the advantages here with IRE is that it's a non-thermal form of ablation, so it's not affected by heat sink. And secondly, because of its mechanism of action, it is very well suited for lesions that are abutting major vessels or the hilar lesions. So for hilar lesions, I think it's a niche technology that is much better than all other forms of ablation. And you compare with RF, it's almost equivalent for smaller lesions. There is no size advantage, but for lesions that are close to critical structures, IRE is very good. with comparable complication rates. The disadvantages are that you have to place multiple needles strategically and very accurately. So there is a steep learning curve. No track ablation is possible. And thirdly, you need general anesthesia, and it's costly. Another thing that has come up in the past 2 to 3 years is histotripsy. Basically, it's an extension of HIFU or high frequency ultrasound. Basically, you are concentrating very high intensity pulses of ultrasonic beam towards a lesion and causing acoustic cavitation, which will liquefy the tumor. It will be cleared by the body's immune system. It recently got its FDA approval last month, actually. And 2 trials have been conducted for histotripsy for HCC in humans. This was the first one, the Teresa trial in 2022. And it showed that for smaller lesions, the median size of lesion in this trial was around 1.3 centimeter. And they showed that it's very good and comparable to other ablative techniques. For larger lesions, the data is still lacking. But the advantage here, obviously, is that it's non-invasive compared to all other ablative techniques. So it's probably going to come up in a big way. Coming to transarterial therapies, the 2 main therapies that are commonly used are TACE and TARE. The conventional TACE basically means that you are going into the tumoral artery and you are using an emulsion of chemotherapeutic agent and lipiodol and injecting it and then embolizing the artery. Now, the problem with conventional TACE, the apparent problem was that the chemo drug was actually getting separated from the lipidol and getting into the systemic circulation. So it was theorized that it will cause more systemic side effects and the tumor will not be exposed to the chemotherapeutic agent for a longer time. So this is where DEP-TACE was introduced, or drug-eluting beads. Here, the idea is that these are small polyvinyl alcohol particles or microspheres, which can be loaded with chemotherapeutic agent, and they can be injected inside the tumor. The tumor will retain these beads, and the beads will slowly release the chemotherapeutic agent over a period of 2 to 3 weeks. So the tumor will be exposed to the chemotherapeutic agent for a longer time, and the chemo will not go into the systemic circulation. So the chances of systemic side effects are less, and the efficacy is supposedly more. And this has been around for almost 10 years, but strangely, all the randomized control trials, whatever have been conducted, they have not shown any clear benefit with DEP-TACE over conventional TACE. Our own experience suggests that DEP-TACE might be useful in patients with a little compromised liver function, late child B, with a large lesion. So what we have seen is that if you use DEP-TACE in these patients, the systemic side effects are less and the efficacy remains the same. Now, all the other technologies that have come up in TACE are trying to basically maximize the tumor dosage, the chemo dosage to the tumor and minimizing the effect on the normal liver. So something called as balloon TACE has come up, and this was recently introduced in India last, I think, two months back. The idea here is that you insert a microcatheter with a balloon inside the tumoral artery and you inflate the balloon. That will create a low pressure zone near the tumor, which will redirect blood from the normal liver parenchymal arteries to the tumor. So you are maximizing drug concentration in the tumor and minimizing the injury to the normal liver parenchyma. So some studies have been conducted of balloon TACE, comparing it with C-TACE and DEP-TACE, and they've shown that the time to progression is better with balloon TACE, although it's all very short-term data, long-term data is still lacking. Another thing that has come up on a technical modification, it's something called as anti-reflux microcatheter. So this is like a basket. Basically, during systole, it will collapse and it will allow the blood to go, the chemo to go into the tumor. And during diastole, it will flare up and it will prevent the reflux of the chemo into non-target areas. So you're trying to again maximize the dosage of drug to the tumor and minimizing damage to the normal liver parenchyma. So this was about TACE. Coming to radioembolization or TARE or CERT or Y90, it has been around for a while, but it found its way into guidelines only recently, last year actually in BCLC. The reason for that was the initial trials, the SARA trial and the Cervinib and the Soramic, they all showed that TARE was not superior to sorafenib. And again, the reason for that was that the dosimetry that was done at that time, the way the dosage was calculated, it was very different. The change that has come up in the last 3 to 5 years is personalized dosimetry. So basically, you are giving more dosage or more radiation to the tumor and minimizing the radiation to the surrounding liver parenchyma. And this has come up in such a big way that studies have now shown that you are going from a palliative therapy to more curative therapies for solitary lesions, which cannot be ablated or which are unresectable and which are more than 3 centimeters in size. So multiple studies in the past 2 years have shown that radiation segmentectomy or personalized dosimetry or ablative tear, which is called now, is potentially curative therapy for early stage HCCs. And now the concept has come up in which tear is considered as a one-stop shop for all liver confined HCCs, be it small or large. With PVTs, you can offer tear and it gives you good response. Now, combination therapies, we heard about it a little bit in the previous talks also. So there are two basically varieties. One is you combine the loco-regional therapies, and second is combine the loco-regional therapy with systemic therapies. So you can either combine TACE or TARE with ablation or SBRT. The idea here is that solitary lesions that are more than 3 centimeters in size and less than 5 centimeters in size, they don't do very well with ablation alone. So you can combine TACE or TARE with RF or microwave. And for lesions which are there with PVT, you can combine TACE with SBRT or TARE with SBRT, depending on the extent of the portal vein tumor thrombus. So combining TACE plus RF, there are two approaches. You can do TACE first, which would basically devascularize the tumor, decrease the perfusion-mediated cooling, and then you do RF to get a larger ablation zone. You can do RF first because the hyperemia that is induced by RF would increase membrane permeability. And then if you do TACE, the drug gets nicely deposited into the periphery of the tumor. So you can do either. Both of them have shown good results. And now there are even randomized controlled trials that have shown that if you combine RF with TACE for lesions that are more than 3 centimeters in size, it gives you better time to progression compared to any of the therapies alone. SBRT plus TACE, again, this was briefly touched in the previous lectures. For patients with PVT, you can do TACE followed by SBRT or the other way around, and it has shown better results compared to a single therapy. There's a lot of talk about combining LRTs with systemic therapy, and the logic there is that majority of the loco-regional therapies have some form of immune modulation. It is shown to be activating the T cell responses, increase PD-1 and PD-L1 expression. So there is a lot of interest in combining LRTs with immune checkpoint inhibitors or TKIs. And number of studies have come up in the last 2 to 3 years. TACE plus sorafenib was the first one. And again, the initial trials did not show any benefit, but the recent ones have shown that with the improvement in technology of doing TACE, with the increase in expertise, what has been seen is that if you combine TACE with sorafenib, the results are better compared to either therapy alone. Then there is a combination of TACE with atezobev, and even comparisons between TACE and atezobev and TACE with lenvatinib, which have shown good results. Thank you.
Thank you, Dr. Rajesh, for a wonderful discussion on the various loco-regional therapies. Do you have any questions in the chat box? Let me see. I don't see any questions.
So can I ask one question?
Yes, sir.
Yes, please.
Yeah, excellent talk. So now you have so many options for ablations, for TACE, for TARE. So when talking about ablation, so since you have got all these options, so what would be your first choice? Whether it would be microwave or others like cryoablation. So when all are available to you, what would be your first choice?
So it depends on the location of the lesion and the size of the lesion, sir. Anything less than 2 centimeter in size, I would not differentiate between RF or microwave. Both are equally good. For 2 to 3 centimeter in size, we personally prefer microwave, although no studies have actually shown that RF is inferior to microwave, but we personally prefer microwave. For lesions that are at the hilum, obviously we don't have access to IRE, but if we had lesions that are close to hilum, we would prefer IRE. Lesions that are close to gallbladder or major hepatic vessels, we would prefer cryo. So this is how we would go. For lesions more than 3 centimeter in size, now as I showed that the newer antennas are doing much better. So between 3 to 4 centimeter in size, we still prefer actually microwave. If the lesion is nice, intraparenchymal lesion, not exophatic, not subcapsular, not close to any major vessels, we would still go for microwave alone, and we have had good results. Between 4 to 5 centimeter in size, I would prefer a combination therapy. Microwave plus TACE.
Does it also depend upon the child or the MELD staging? Do you have any relevance to this?
Definitely, sir. Definitely, sir. So we prefer a child A or an early child B. But for ablation, obviously, you can actually go up to late child B and early child C also. Although the guidelines don't suggest that. We prefer to do it with patients with preserved liver functions. Child A or child B.
Do you have any preventive strategy whenever you do these therapies to reduce the post-therapy complications?
You're talking about ablation, sir?
Ablation, yes.
Not really, sir. I think they are very well tolerated. And we usually discharge the patient the next day itself. And if the lesion is very small and the patient is well preserved, we have discharged the same day also. I think it's very well tolerated. We have never had any major issues so far. So no preventive strategies as such. We have never felt the need.
Okay. Any questions? Dr. Ashish or
Dr. Ajay has a question, I think.
Ajay has some questions.
Very nice talk, Rajesh. I would say, I think very nicely covered topic. I don't know how many other centers have it, but we were the first one in the country to have IRE at PGI Chandigarh. And 4 years back, we had published our experience with a small number of patients. So I think IRE has a place because it's a non-chemical, non-thermal, and as you rightly said, for higher lesions, I think it really has a place. But the disadvantages are the multiple probes which have to be put in under general anesthesia. So that's the major issue, and the cost also comes into that. So I mean, we have been using this for peripheral lesions also, where you can think of a more of a collateral damage. So my question to you is, earlier, the radiologists used to do something called the artificial ascites creation around these peripheral lesions, so that the heat sink and the collateral damage doesn't happen. Is it still valid, or you stopped doing this?
We have all done it in our fellowship days,
yes,
early days. But frankly speaking, sir, with the advent of SBRT, we fortunately have access to SBRT. So now we are sending more and more patients who have subcapsular or exophatic lesions for SBRT, and the results are excellent.
Yeah.
So you can technically do it, and people are still doing it who don't have access to SBRT. So you can create an artificial ascites with 5% dextrose, and you can ablate the lesion safely. But I feel that the results of SBRT speak for themselves. I think in our center, we are sending more and more patients for SBRT with lesions that are close to these controversial, difficult areas.
Yeah.
There's a question in the chat box. So what is your experience with response rate in tumor thrombus in portal vein branch?
I'm assuming it's for TARE or SBRT, sir. Basically, it depends on the extent of tumor thrombus. If it's a VP1 or VP2, basically a segmental tumor thrombus, and the patient is well preserved, we have actually done TACE also for these patients. And if needed, combined it with SBRT. If the patient can afford it, obviously TARE would be better than TACE. For VP1 and VP2, the response have been excellent. Even if you do TARE alone or with SBRT combination therapies, it's been excellent. But for VP3, VP4, obviously, when the main portal vein is involved, the long-term response has not been very good, sir.
Okay. So I have one question about radiation segmentectomy, which you talked about. Can you dwell upon it a little more? Which are the patients which you offer And how does it compare to other ablative therapies like RFA or microwave with this radiation ablation?
Yeah. So basically, radiation segmentectomy means that you are delivering ablative doses of radiation to one or two segments of liver in such a way that you're not affecting the rest of the liver. You're preserving the liver function so that the patient does not decompensate. The idea here is that you're taking care of the tumor and you're taking care of all the microsatellite nodules and the microvascular invasion that might have been there. And what has been shown is that it's equivalent to RF and microwave for smaller lesions also. So there was a trial last year from US. It was called the RAZOR trial. And what they did was for lesions that were less than 3 centimeter in size, which would have ideally gone for RF and microwave, but they could not because the location of the lesion was difficult. I mean, it was either subdiaphragmatic, paracardiac, close to gallbladder, close to colon or stomach. And in these patients, they did ablative tear or radiation segmentectomy, and they showed that the results are equivalent. So it has come up in a very big way. So we are giving more doses of radiation to the tumor as well as the surrounding segment, maximum 2 segments, not more than that, and getting better results, almost curative.
Well, I think we had a good understanding of the various procedures. Thank you, Rajesh, and then we will take it back to Ashish.
Thank you, Dr. Shenoy. And so now, thank you, Speaker and Dr. Shenoy. So we move on to the next topic. Technical team, can you display that? Yeah. So the next topic is on systemic therapy for HCC, current and upcoming drugs and combination. And to moderate this session, I would invite Dr. Aju Matthew. He is a consultant at Kerala Cancer Care Kochi. He's a medical oncologist, and I would ask him to take over the session and introduce the topic as well as the speaker. Dr. Aju Matthew, over to you.
Thank you. HCC is rising. We all know that. And unfortunately, majority of the HCC that we see are still in a non-curative setting. In such a setting, what can we do to prolong life at decent quality of life? That is the biggest question that we as medical oncologists encounter. And that is the topic that our illustrious speaker, Dr. Anand Kulkarni, will talk about. He's a consultant in hepatology and liver transplant at AIG Hospital, Hyderabad, a very accomplished researcher and leader in the field. Let me, without much delay, invite Dr. Kulkarni to deliver his talk.
Thank you. Thank you, Team INASL, for inviting me. I know it's quite late and everybody is hungry, and we're all missing Kerala. So probably we'll be meeting at 2024 Kerala INASL. I'll be talking about systemic therapy for HCC. What are the current drugs? What is the main aim in HCC treatment and how to achieve it? A little bit of combination. And these are the drugs which are already available. Sorafenib, which came in 2007, then came the lenvatinib. These are the first line drugs. Atezolizumab, which is available in India. Durvalumab, which has recently been shown to be very effective, just published in NEJM evidence, but still not available and not quite economical. And the second line drugs which are available in India are cabozantinib, regorafenib, ramucirumab, and the other ones which will be available later on, or we will have more experience with these drugs, are nivolumab and ipilimumab and pembrolizumab. So first line drugs, these are sorafenib and lenvatinib. They had good efficacy. Sorafenib almost ruled the world for almost a decade. The only caveat of all these drugs is they are usually used for patients with child A cirrhosis and BCLC B or C with no prior systemic therapy. Both these drugs have similar adverse event profile, and both these drugs did not achieve complete response, which is usually seen with patients who receive the currently available immuno-oncological agents. While in sorafenib arm, there was very few patients. In lenvatinib, only hardly around 0.5% could achieve complete response. Well, objective response rate was quite good, which is 25%, which was seen in this lenvatinib. Yes, sorafenib gave some hope of survival, but usually the patients lost to follow-up. And while in lenvatinib, there was much patients who came for follow-up, a little struggle with hypertension and available. The other adverse event which used to face is hand-foot reactions and oral ulcers, fatigue with this drug. But it was quite good. It is still continues to be quite excellent drug for patients who are not affordable for immuno-oncological agents. Lenvatinib does have good efficacy. In our real-world experience, it gave an overall survival of around 10.4 months with median progression-free survival of 5 months. But none of the patients achieved complete response, and hypertension and liver dysfunction has to be monitored for these patients who are on lenvatinib. The maximum tolerated, the medium tolerated dose in our cohort was 8 mg, as opposed to what is recommended. It is 12 mg for more than 60 kilos and 8 mg for less than 60 kilos. So basically in India, probably we started 4 mg, then increase up to 8 mg. In our personal practice, I haven't gone beyond 8 to 10 mg until now. The second line drugs which are available are regorafenib, cabozantinib, and ramucirumab. One unique difference about ramucirumab, it is used for patients who have progressed on sorafenib or were intolerant and had an alpha fetoprotein more than 400. That basically indicates that the patient has more of VEGF, and REACH 1 study showed that ramucirumab is more effective when the alpha fetoprotein is more than 400. While other two drugs are similar, they must have tolerated and progressed on sorafenib. They must have tolerated and progressed on sorafenib. Then only we initiate either regorafenib or cabozantinib. Again, as we see here, very few patients achieve complete response, but objective response rates ranges somewhere between 5 to 10%, and have a unique similar adverse event profile, which is diarrhea, proteinuria, nausea, fatigue, and hypertension. Coming to the various IO agents, actually 2018 there was a Nobel Prize for the discoverers of this PD-1 and CTLA4 investigators that gave breakthrough to all the immuno-oncological agents. And these drugs have become first-line therapy. Arjun may actually agree with us that many of the available cancers now, lung cancer, many of the cancers, breast cancer, almost all, they have been using immuno-oncological agents in the recent years. The one which is available in India is atezolizumab. All of them have a common inclusion criteria that a good performance status, BCLC B or C with child pug A. The dosage varies. In atezolizumab, we start at 12 mg, atezolizumab plus bevacizumab 15 mg per kg, while the stride is durvalumab 15 mg for every 4 weeks. Before that, we start at tremelimumab 300 mg single dose. And the third one is, which is recently published in JAMA Oncology, is tislelizumab, which is PD-1 inhibitor, 200 mg every 3rd week. All of them have a decent survival. The best among them till now stands out to be atezolizumab with the overall survival of 19.2 months and progression-free survival of 6.8 months and objective response rate of 30%. The availability of this drug and with the approval of the FDA, there has been significant increase in the use of this drug in US particularly, and also probably in India to some extent. The use of this drug has increased up to 70%, and the use of the tyrosine kinase inhibitors has reduced to less than 10%. This will probably reflect our practice also in near future time. In coming days, we will also see that most of the patients are on these drugs of immuno-oncological agents, and all hepatologists should be aware of these drugs and the adverse events which they cause. Why we are using this atezolizumab is basically the reason is it has good overall survival and has excellent progression-free survival, which has been shown to be 6.8 months compared to sorafenib, which has 4.3 months. However, the patients who responded to therapy, these were the patients who had good performance status, good child pug score, and they were compared against sorafenib. And when we initiate a patient on atezolizumab, we tend to do a MRI or CT scan, preferably a MRI or CT scan every 6 weeks. This was actually recommended, but in our clinical practice, we tend to do after 3 doses of immunotherapy, and we monitor liver function test and alpha fetoprotein frequently before initiating the next dose of atezolizumab. These are patients who had alpha fetoprotein more than 400, only in 40% of patients had similar baseline data. But considering these patients who have strict criteria, all of them very excellent child pug score and performance status, we wanted to assess whether it's effective in advanced stages as well. This was our study from AIG and Jaipur, where we had around 67 patients who received atezolizumab, and we showed that patients who have good liver functions, they have better overall survival and progression-free survival. Although child pug also fared well, but child C definitely a no for any kind of therapy. We also performed a meta-analysis of around 47 studies and 5,400 patients, and we found that it is almost comparable, objective response rate and disease control rate almost comparable in patients who receive atezolizumab for HCC, unresectable HCC. But why would I suggest IO over a TKI? The reason behind this is the NIGM study, which says that complete response is seen in a good amount of patients, that is 27.3% objective response rate. Once you achieve objective response rate, there is good fair chances that the patient may undergo a curative therapy, either a surgery or a transplant probably, compared to patients who receive sorafenib, where on RECIST criteria it's hardly 12%, on mRECIST around 14%, while on mRECIST criteria, the proportion of patients achieving objective response rate is 33%. That is good number of patients can be bridged to a curative therapy. Disease control rate also includes, apart from complete response and partial response, stable disease. So this stable disease was also quite good in these patients who received atezolizumab in this trial. When we compared cumulative effects of all the real-world studies and the available data, we found that the progression-free survival, objective response rate, disease control rate was much better with atezolizumab than with TKIs with lesser mortality. So can we combine TACE with TKI and have a patient who has received atezolizumab? There have been no combination studies comparing this, that is combination of TACE plus TKI versus atezolizumab or TACE plus atezolizumab. But if you see that there are some studies which are shown as discussed by previous speaker as well, combining TACE plus TKI, it may increase the time to untraceable progression, but none of the studies have been able to prove that there is improved overall survival. Similarly, this was thought, I think, shown by Dr. Ashish Kumar also as well. The patients who received TACE plus lenvatinib have better survival compared to patients who received TACE plus sorafenib. So TACE plus lenvatinib may be used in select patients. I usually don't prefer to add lenvatinib to all patients. Only if the alpha-fetoprotein is high, or the patient has multiple lesions, or the patient, we feel that the patient is high risk of patients hepatitis B with borderline alpha-fetoprotein, then we tend to add any of the TKIs, but it is not blanket advice for all the patients who undergo TACE. Why we avoid atezolizumab in our clinical practice? We see that many of the individuals wherever I have spoken with, they fear two things. One is bleed, the other is immune-related adverse events. But when we try to assess the incidence of variceal bleed, it's hardly around 5%, and the incidence of bleeding is similar between child A and child B, although it is little higher in patients who have main portal vein thrombosis, and bleeding is similar irrespective of the prophylactic therapy. So performing a ligation or giving a beta blocker is almost similar. So it is better to start them on beta blocker. Performing a ligation prophylactically just to initiate the drug may increase the risk of variceal bleed or mucosal bleeds in these individuals. Immune-related adverse events are seen around 10.2% of individuals in this meta-analysis as well. So bevacizumab has been available since 2004. It was considered as a drug which is in search of some disease, but I think HCC is in combination with atezolizumab, it does pretty good results for this patient with unresectable HCC. Bleeding is unusual but fatal. You can treat with carvedilol, propranolol, or endoscopic variceal ligation as per your preference. But in the NEGM study, they said they had eradicated the varices prior to initiation of the therapy. Lastly, simvastatin has some evidence of reducing portal hypertension. If you feel that the patient is not fit for any kind of fit for a carvedilol or any of the beta blockers, you may initiate simvastatin if you are comfortable with. And how to overcome or prevent adverse events? The recommended dose of atezolizumab is 1200 mg and bevacizumab is 15 mg per kg body weight. But there have been few studies which have said that there is evidence that the patients who receive lower doses, that is 5 to 7.5 mg of bevacizumab or a fixed dose of 500 mg bevacizumab, can also give effective results without any added adverse events. So I would still suggest to avoid EVL, prophylactic EVL in patients with main portal vein thrombosis, and initiate beta blockers if the map allows. Lastly, immune checkpoint inhibitors have been notoriously known to cause autoimmune hepatitis, and it is more common with patients who receive ipilimumab plus nivolumab, and followed by durvalumab, and thirdly atezolizumab, which is reported in up to 10% of the individuals. It occurs after 1 to 3 doses. If a patient has come with, that's the reason we tend to monitor these patients for LFT prior to initiation of the next dose. Check for LFT, if there is elevation in the enzymes and the bilirubin, get a IgG done. ANA may be negative because only 30% may have ANA positivity, but IgG will be pretty high in these individuals. And you initiate them on therapy, they do okay. And there is some evidence that you may also re-challenge, but as of now, I have never re-challenged the patient who has developed immune checkpoint inhibitor related autoimmune hepatitis. Does etiology matter in systemic therapy? We discussed in the first few talks that etiology has been changing in India, but for this atezolizumab drugs, or for that matter, any of the IO agents, they work similarly irrespective of the etiology, be it objective response rate or disease control rate or the progression-free survival. They have similar efficacy irrespective of the etiology. How to identify who respond to therapy? There are many of them which have been reported in the literature. And if you go for PubMed, there are many of them which have been reported. What we commonly use in our clinical practice is alpha fetoprotein. Higher the alpha fetoprotein, the chance of response is little low. Higher the patient has extrahepatic mets or adrenal mets, they usually do not respond to therapy. And lastly, there is a recent study in Nature which said that if you do a biopsy and you find a patient, the tumor has higher CD8 and CD274, then you may identify an individual who will respond better. So higher CD8 and higher CD274 can identify a patient who will be usually be responsible for response to this therapy. The problem with this drug, with this biopsy, is identifying a pathologist who can give us a report of this. That's the major concern for us. But this gravity score, which has come in Journal of Hepatology, said that if you are giving immunotherapy for these individuals, check for CRP and alpha fetoprotein. If it is low, both of them are less than 1, then the patient, both of them are in the lower range, then the patient has better survival when you give a immunotherapy. But this has not been validated elsewhere in Asia Pacific region. I am not sure of any of the studies which have been validated, because CRP is quite heterogeneous and not quite frequently used in our setting. Then how long to continue these drugs when the patient has been initiated? According to Kudo, he says that 80% of the individuals respond to therapy, that is complete response or partial response is achieved within 4 doses, and another 20% by another next 2 doses. So if the individual has not responded by 4 to 6 doses, it may not be prudent to continue the therapy for these individuals. And what should we do now? It is better to combine loco-regional therapy with atezolizumab plus bevacizumab. Our experience says that patients who have received DARE plus atezolizumab, 2 have achieved complete response, 2 have undergone transplant, and 3 have achieved partial response. The basic reason, as Dr. Shashidhar was alluding to, that when you do a loco-regional therapy, it creates an immunogenic environment, and when you start immune checkpoint inhibitors, the patient responds well to therapy. There is a recent study, a retrospective study, combining SBRT plus nivolumab. They showed that there is better overall survival in the matched cohort who received IO agent plus SBRT, but this is yet to be replicated elsewhere. It's a recent study which has been published. All patients had received a median of 9 cycles of nivolumab 14 days after SBRT. Then there are a few studies which have combined tyrosine kinase inhibitors with IO, and none of them have been successful, and there is no strong evidence to support the use of IO plus TKI agents till now. Then combination of loco-regional therapy plus systemic therapies, there is RCT which is ongoing. Lenvatinib plus pembrolizumab plus TACE compared with placebo plus TACE, but the results are still expected. It's a beautiful article which is published in Liver Cancer, how to treat a patient of HCC and how to, the aim is to cure the disease and keep the patient cancer-free and drug-free. So there are multiple ways. Either you do a loco-regional therapy, combine with systemic therapy, or you start them on immunotherapy and then combine with loco-regional therapy. Just make sure that the patient is cancer-free and drug-free. We have been seeing that the patients who have been receiving this drug have good number of patients have survival more than 10 months to 12 months as of now. Is transplant feasible after IO agent? The stronger data is for nivolumab. Data on atezolizumab, there are only 3 case reports, and the risk of rejection is quite feared, and it is evident that the patients who undergo transplant earlier, that is 3 cycles, the half-life of this drug is 21 days. If you do it before 90 days, the risk of rejection is pretty high. It is preferred to do after 90 days once you start this, once you stop this drug. To summarize, the tyrosine kinase inhibitors are economically easily available. They provide a decent overall survival. There are no unusual adverse events. They still have some adverse events, but complete response is rare, and bridge to transplant, which is the curative therapy, is usually rare. On the other hand, immuno-oncological agents, the complete response is not uncommon. It gives excellent overall survival. Bridge to transplant is feasible. The only caveat with this is it is not economical, not easily available, and we should be aware of unusual adverse events which may be seen with this drug. Thank you. Any questions? I'm open to answer.
Thank you, Dr. Kulkarni. Excellent talk. I wasn't aware of Gratify score. I think one of the urgent needs in this field is identifying a biomarker. I think in the interest of time, I'm going to pass on the question and allow the organizers to move to the panel discussion. Excellent talk once again. Thank you.
Thank you, Dr. Aju. Thank you, Dr. Anand. I think you've covered most of the part of systemic therapy, including combination therapy. Just one question. So are there any ongoing trials on TKIs now, or all the trials now have switched to immuno-oncology?
They are combination of TKIs plus immuno-oncological agents, as of my knowledge, sir.
But no new TKIs are coming up after?
I am not aware of that.
Okay. So the immuno-oncology drugs have not taken off.
There are some in China which are ongoing, but I don't know what will be the results.
Okay. So thank you for this session. So now I will move on to the next session. So next session is a case discussion or panel discussion. And the panelist for this session will be Dr. Arun Walson, who's an assistant professor at Amrita Institute of Medical Sciences, Dr. Sojan George, who's an associate professor at Amla Institute of Medical Sciences at Thrissur, and Dr. Nosif M., who's a senior consultant and liver transplant surgery at Aster, Calicut. So I would hand over to the panelists to introduce the speaker as well as then begin the case discussion.
So can I share my slides?
Yeah. The speaker is Dr. Charles Panicle. Yeah.
Thanks. So good evening all, and thank you Professor Ashish and Professor Tuseja for this opportunity. It's my esteemed panel, and we'll be talking about a 64-year-old male who is a non-diabetic and hypertensive. He was evaluated outside for a right hypochondrial pain, and he was found to have grade 3 fatty liver. The ultrasound showed a grade 3 fatty liver. There was a space-occupying lesion on the right lobe, no PVT, no ascites, and he was referred to us for further evaluation. His liver function tests were normal. INR was 0.8 and platelet count was 2,02,000. And in our hospital, we proceeded with the MRI that showed a right lobe lesion that was 5.3 in 5 centimeter in segment 5 and 8. And it showed arterial phase enhancement with washout in the venous and delayed phases. And there was a subcapsular fluid collection, history of a contained rupture. And there was no ascites, there was no portal vein thrombosis. And liver was smooth in outline and there was no volume redistribution. Dr. Arun, when you see such patients in your practice, would you biopsy them or are you happy with the MRI diagnosis?
Good evening. Thank you for the question. I hope I'm audible. Am I audible, sir?
Yeah, you're audible, please.
So in a case, this particular patient looks non-cirrhotic to me because his platelet is normal, albumin is normal, his imaging is consistent with a non-cirrhotic phenotype. So in these kind of patients, biopsy is recommended. So I would go ahead and do a biopsy mainly to see the biology of the tumor and also confirmation as well for the diagnosis. So I would biopsy this patient.
And if he is a cirrhotic, what are the situations where you biopsy in your practice?
So basically, the LIRAD score that we use is pretty good, and we can use that in most of the cirrhotic patients. A few patients whom we can't use are, people less than 18 years of age, where it's not validated, and cirrhosis due to vascular diseases like congenital hepatic fibrosis, Budd-Chiari, chronic portal vein obstruction, etc., and hereditary hemorrhagic telangiectasia. So in these patients, these criteria are not validated. And outside of cirrhosis, we can use these in a chronic hepatitis B with a PAGE score of more than 10. And also people who have had a concurrent or a prior diagnosis of HCC, there also we can use LIRADs.
Yeah, thank you, Dr. Arun. And non-cirrhotic HCCs, you need a biopsy to confirm the diagnosis. And coming back to the case, the endoscopy, there was no viruses. We did a fibroscan. The CAP score was, it's 310 dB. And elastography was 10.8 kilopascals. His wire markers were negative, ferritin was 390. And AFP was 420 nanogram per ml, and DCP was 1280. So, Dr. Naushif, as a surgeon, what are the surgical options in this patient? If you see this patient in your clinic, what are the surgical options would you give them? Naushif,
yeah, I'm audible?
Yeah, you're audible.
So we have a patient with HCC, probably HCC 5 centimeter lesion, around 5 centimeter lesion, without any clinically significant portal hypertension. So what we will aim is to provide a curative option. So from the surgical point of view, we have two options. One is surgical resection. The second is transplant. So the call for a lesion like this, it's pretty difficult in the initially. So first of all, what we have to say is like we as surgeons, we look at 3 or 4 main our considerations will be like, we look at the liver, whether it is cirrhotic versus non-cirrhotic liver, whether there is any clinically significant portal hypertension or not. And the most important is the FLR, the future liver remnant. So we look at the liver remnant volume as well as the quality. So whether if you have a normal liver, up to 20 to 30% is acceptable. If it is fatty, 30 to 40, and if it is cirrhotic, 40 to 50% should be there as FLR. Now, the next consideration for us will be like, should we go for anatomical segmental resections or sectoral resections, or should we go for a non-anatomical resections if we need to preserve volumes? So our considerations will be like location of the tumor, the remnant liver, and the reserve. As we already mentioned, like here, like we look at the HPPG, varices, presence of ascites, shunts, platelet counts, and if needed, fibroscans also. So the primary aim here will be like outcomes of survival outcomes as well as recurrence outcomes. If you look at the outcomes, data has shown that the recurrence or survival outcomes of resection versus transplant is not much different. So always for lesions like this, we give weightage for resection rather than transplant. And transplant will be considered if we have any high-risk features on or unfavoring tumor biology. We'll come to that later.
Yeah, thank you, Dr. Naushif. And Dr. Sojan and Dr. Arun, do you routinely do HPPG in your practice, or are there any indirect markers that we can use in clinical practice? Arun, you want to take it? Sojan, you are there?
We do not do HPPG routinely in our practice. Basically, we look at an endoscopy for varices. We look at the fibroscan value and the platelet count. That's what we do.
We are also not using HPPG as a matter of routine now. Only in selected cases where there is doubt, only then. Otherwise, no.
Thank you. So coming back to patient, he had a NASH with F3 fibrosis. The performance status was 0 or no major comorbidities. Basically, he had a non-cirrhotic HCC, and we did a staging PET that showed a PET positive lesion. The maximum SUV in the liver lesion was 6.9. There was no extrahepatic spread, and there was a doubt of a content rupture of the tumor. Because of the doubt of the content rupture of the tumor, we did not do a liver biopsy. We directly proceeded with the surgery. And the patient underwent a lab non-anatomic resection of segment 5-6 on Jan 2022. And this is a biopsy. It showed a lesion with moderate to poorly differentiated. There was no vascular invasion, and there was a contained rupture, breach of the liver capsule. So, Dr. Arun, is there any evidence to use adjuvant therapy in patients who undergone liver resection or curative therapies?
So the overwhelming data for adjuvant therapy post ablation or resection is for tumors which are large in size, particularly in this case if it's more than 5 centimeter. So here it's around 5.5. Then you have multiple tumors, or you have poorly differentiated tumors, or you have vascular invasion. So in this patient particularly, since they have a large lesion of 5.5 and there is some satellosis present, there is a case for doing adjuvant therapy. There are multiple adjuvant therapies that have been studied, like TACE and sorafenib, and also the latest atezolizumab, bevacizumab. So TACE, I'll just quickly finish. TACE, around 7 studies are there, 1 from Japan and 6 from China. Except one study, all of them said that there's a improved overall survival and a progression-free survival. And for sorafenib, the data is kind of heterogeneous. So the STORM trial was the largest trial which did not show any benefit. But there are recent studies which say that sorafenib decreases the, in fact, increases the progression-free survival and overall survival. Coming to atezolizumab, bevacizumab, this was this a global study of a phase 3 study where they compared in child day cirrhotics with post-ablation and or curative resection. They compared patients with performance status of ECOG 0 and 1. Patients could have had 1 or 2 sessions of TACE after 4 to 12 weeks, and then they randomized them into either atezolizumab, bevacizumab, or an active surveillance arm. So when the interim analysis was done, they found that the primary outcome was met. That is, there was recurrence-free survival was met, but the overall survival was not, but that was not the primary outcome. But there were 7 additional deaths in the atezolizumab, bevacizumab arm. And the point to note was that there were similar deaths due to HCC. And 3 additional deaths due to COVID within the 1 year of randomization. So we don't know the overall survival data, but at least the recurrence-free survival is better in the atezolizumab, bevacizumab arm.
Thank you, Arun. And we proceed with the case. Unfortunately, we did not put him on any adjuvant treatment, and he was followed up with serial CTs and alpha-fetoprotein. He did well till April 2023 when the alpha-fetoprotein started to rise, and the CT, we took a CT at that time and showed multifocal recurrence. Dr. Sojan, when you have multifocal recurrence in patients who non-cirrhotic HCCs who have undergone resection, what are the treatment options and what would you offer here?
Yeah, thank you, Dr. Charles, for that question. So this was a patient who had a non-cirrhotic HCC, underwent non-anatomic resection. Close to like 16 months later, patient has had a recurrence, and that too in the form of a multicentric HCC. So basically, when somebody comes with a recurrence, what we look at is he falling to within the Milan criteria or beyond that? So if the recurrence is within Milan criteria, then obviously we offer them a salvage liver transplantation. But if he is beyond Milan criteria, then we look at whether he can be downstaged or not. If he fits into the downstageable criteria, then probably we give a locoregional therapy, see if he responds well to that, and then offer him transplant. On the other hand, if the recurrence is with vascular invasion, extrahepatic spread, or if the patient is unsuitable for transplantation, then probably systemic therapy would be the go-to option.
Yeah, Sojan. Thank you, Sojan. And Dr. Naushif, as a transplant surgeon, would you offer him a salvage transplant here? Or would you have done a transplant immediately after you saw the biopsy that showed the poorly differentiated tumor?
Yeah, if you look at the biopsy, there are 2 things which are a bit worrying. One is the presence of satellite lesions. The second is the size. Okay, even though there is no microinvasion, and the one more is the differentiation. It's a poorly differentiated tumor. So there are limited data on the use of ab initio upfront liver transplant for those patients, upfront salvage. That is like you do transplant before the occurrence of recurrence. So, but though limited literature is there, it's very early to say whether it will help or not. But if you look at the available data per se, even this case, transplant should have been considered, not at that time, but the suspicion of recurrence. So why? Because the outcomes after transplant, after primary liver transplant as well as salvage liver transplant is shown to be almost same. So even it's up to the tune of 70% of 5 years survival can be achieved even with salvage liver transplant. So what I would prefer is you have to prioritize liver transplant at every point of time. Whatever option you consider, you have to prioritize liver transplant. So in this case also, you could have thought of transplant at that time. So we know the issues with transplant, main issue, our main concern is the availability of donor livers and the transplant specific complications. But the other way, you remove the diseased liver, reduce the incidence of de novo recurrence again. So all these are advantages which should be weighed against the issues, potential issues which we face with transplant. And we look at the recurrence pattern data. It's also largely similar between primary liver transplant as well as salvage liver transplant. And the exact criteria for salvage liver transplant is yet to be established. When you look at the data, there are limited literature, but still, when you have a recurrence within 8 months after the local resection, or when you have a very high AFP level, maybe more than 200 or 400, and when you have the lesion outside the Milan criteria at salvage liver transplant, these are shown to have, poor recurrence survival after transplant. And tumor biology should also be considered here, mainly presence of satellite nodules, invasion, microvascular invasion, and poorly differentiated tumors. So all these, if you have all these, then you should suspect that you are going to have a poor outcome even after transplantation.
Yeah, thank you, Dr. Abhishek. And a patient unfortunately did not have any donor. There's no options of cadaver in Kerala at present. So he underwent the ablation of the lesions with CT and ultrasound guided ablation. And following ablation, he was put on lenvatinib 8 milligram. And within few weeks, he started to have diarrhea, oral ulcers, and the lenvatinib dose was reduced to 4 milligram. And in June 2023, presented with severe backache and right lower limb weakness. AFP again went up to 940, PIVCA was more than 12,000, and a whole body PET CT was taken. And this is what the PET showed. There were multiple lymph nodes in the mediastinum with that were PET positive, and there were bone mets. Right second rib, the right pedicle and transverse of D8 vertebra, the L2 vertebral lesion, and the left acetabular. And all these lesions were PET-avid. So, Dr. Sojan, patient, do you think there's any other option for this patient? He saw on lenvatinib, has progressed on lenvatinib, even though he did not tolerate the dose, full dose. He has progressed, and do you think there are any options in this patient?
Yeah. So this was a patient who has had two unfortunate things. Once he had to reduce the lenvatinib dosage. Secondly, he has progressed and he fits into the definition of a progressive disease. So what are our options? The second line basically depends on what first line we have used. So if it is somebody who is having an atazobev initially, then the next go-to drug would be sorafenib or lenvatinib, cabozantinib, or regorafenib. But in this case, in this patient, actually patient was initially started on lenvatinib. So our go-to option would be cabo, regorafenib, ramucirumab, etasbova, and pembrol or nivolumab, which will be later on available. Now, what is important to note is that since this patient had an initial intolerance, probably ramucirumab will be a go-to drug. Though the AFP criteria is not meeting, as was discussed in an earlier session, patients who are intolerant to lenvatinib would rather respond better to ramucirumab.
Yeah. Thank you, Sojan. And we proceeded with the, because of the weakness and severe pain, we proceeded with the RT2 D8 lesion, and followed by we did a decompression of the D8 and the L3 and fixation because there was a weakness of the left lower limb, right lower limb. And patient did well following the surgery. He was again mobile. The performance status improved to 1, and the liver functions remain good. So we put him on atazobevimab because the company came up with a new offer so that the patient could afford it, and they gave him on the subsidized rate atazo plus we used generic bevacizumab. And he received 6 cycles of atezolizumab. The AFP came down to 96 and Pivka to 580. And in November last week, we did a CT that showed there was a resolution of the lymph nodes in the mediastinum, and there was partial resolution of the bone lesions. SUVs had come down, and the reblation had completely resolved, and the SUVs in the D8 and L2, L3 lesions have drastically come down, and all the mediastinal nodes have disappeared. So hopefully it's one of those cases that responds to the atezolizumab. About 30% of your patients would respond to atezolizumab, and he probably falls into that category. So to summarize, HCC, it requires a multidisciplinary team approach, and we have multimodality treatment options that can give a reasonable overall survival and good quality of life to your patient. And we should also know that the concept of treatment stage migration, where you start with the curative intent with the resection or transplant, and patient can have recurrence or progression of disease, and you end up doing palliative treatments like taste care or systemic therapy. But you should also remember that some of your patients who present with decompensation, acute decompensations, these patients, you can optimize them. So you can treat them with albumin diuretics, reduce the ascites. You treat the decompensating event, and they can recompensate, and they may be candidates for curative treatments in future. And also intermediate and advanced HCCs can be downstage to transplant. So HCCs, you should always have a multidisciplinary approach, and my multidisciplinary approach should be there to prioritize treatment for your patients. Thank you. Thank you so much.
Thank you, Dr. Charles. I think the last two comments which you made are most important, that for every HCC case, it should be discussed in a multidisciplinary team, and the best treatment at that point of time should be offered. And then you should be open to treatment stage migration. So if the patient is decompensated, we can optimize, and then we can offer a better treatment when he becomes compensated. If he is having advanced disease, we can offer systemic therapy and loco-regional therapy, but with treatment, he can be optimized, and maybe liver transplantation can be offered at a later stage. And if some treatment is not offered, we can move on to the next stage. So both these points are very important, and I think that should be the take-home message from this case as well as the entire presentation. Thank you, Dr. Charles, and thank you all the three panelists for the excellent case presentation. So I think you can stop sharing the slide. So we have come to the end of this session, and I would, before handing over back to Dr. Ajay, I would like to give a vote of thanks to all the speakers and all the moderators and panelists for this session, and also thanks to the technical team and the Maisha team for excellent, flawless event. I would also extend my thanks to the Roche for giving the academic support to INASL for conducting all 6 of these sessions, HCC clinics. And now with this, I would hand over back to Dr. Ajay for concluding remarks.
Thank you, Dr. Ashish. And again, I have, on behalf of the Governing Council of INASL, it's my pleasant duty now to thank all the faculty for this, this edition of INASL Clinics on HCC, all the moderators, speakers, panelists. I think I would say this was one of the very educative, I would say, a session. Overall, I think a lot of learning, and I'm pretty sure, and we've had, let me tell you that the last I saw on the WhatsApp, we have had more than 200 registrations, and more than 150 were live there, and around 40-50 were live on YouTube. So I think these days to have this kind of attendance in a virtual or in a webinar, I think is speaks about, the kind of academic, standard this series of, INASL clinics has maintained on HCC. And with this, in addition to the thanks to the faculty, I have to thank the INASL task force on HCC, all our mentors, chairpersons of, INASL task force, and above and all, the convener of the task force, Dr. Ashish Kumar, for doing this wonderful job. And yes, and obviously our thanks to our academic partner, Roche, and to the, our conference managers, Maisha, who have done really a wonderful job. So I think before I say goodbye, I must say that this is the end of the series, 6 of the series of INASL, clinics on HCC. But we are going to come back next year in a different format, and this learning on HCC and various diseases will, continue. And we will also take this opportunity. Dr. Charles Panicle is here, and the whole Kochi and the INASL team is here, that to welcome you all for the annual meeting of INASL, which will happen in the second weekend of August, 7th to 10th of August in 2024. And the registrations and the abstract submission will soon open, maybe by next month. So anything, Dr. Charles, you want to say on that account, or before we close this?
No, sir, nothing to add there. Thank you, sir.
Thank you all. Thank you and good night. Thank you.
Thanks.
Thank you.
Thank you, sir. Good
Thank you.
night.